We are live.
Yes. Good morning. It gives me a great pleasure to welcome you all to the second edition of our webinar, The Next Gen, the Uveitis lecture competition organized by Uveitis Society of India. Today's session is especially exciting as we have with us the next generation of young Uveitis specialists. They will be sharing the knowledge and insights through the innovative and engaging style of teaching. Having had the opportunity to watch the first session and had an additional time to refine the material, today's presenters are very well prepared and we look forward to an outstanding academic experience. I would also like to express my heartfelt gratitude to our esteemed panel of judges, Professor Amod Gupta, Professor Neri, Dr. Reena, and Dr. Rohit Chawla for taking the time to join us today and for the valuable inputs and in-depth discussions that greatly enrich this competition. I wish all the participants the very best for the presentations. I'm confident that we are in for an engaging and insightful learning session. With that, I would now like to hand over the proceedings to our Secretary, Dr. Parthav Pratim Datta Majumdar, and Dr. Arshi Agamat, who will be moderating today's session. Thank you once again, and I look forward to an inspiring and interactive set of presentations. Over to Dr. Arshi.
Thank you very much, ma'am. A very good morning to all of you. Dr. Padma Malini ma'am has kickstarted the second phase of NextGen USI, and we had a resounding success with phase one of this series, of this unique series. And I'm sure that everyone today is very eager to listen to the next set of 8 uveitis enthusiasts. So before I introduce our speakers and start the session, it is my great pleasure and honor to introduce our judges and our esteemed faculty who are joining us back again today. So requiring no introduction, Dr. Amod Gupta sir, teacher par excellence and a scientific mind like none other. It is a privilege, sir, today that you are here to guide the next generation of USI. And not only them, we all look forward to learning from you always. A very warm welcome to you, sir. Our distinguished international faculty, Dr. Neri, who's joining us from Abu Dhabi again today. And you really inspired our last set of speakers with such positive feedback and encouragement. I'm sure that the next set of speakers today are equally excited to listen to your feedback today, sir. A very warm welcome to you too. Joining us from Delhi, Professor Rohan Chawla from our very prestigious All India Institute of Medical Sciences. So sir brings not only his vast experience in managing uveitis, but also mentoring so many students along his distinguished career. We are very, very happy to have you, sir, today. A warm welcome to you too.
Thank you.
And I would like to really welcome and extend my heartfelt thanks to Dr. Reena, who's joining us all the way from Indonesia. And she's a truly passionate uveitis expert. And she really endeared herself to our last batch of students with such kind and gracious words that I'm sure everybody's again looking forward to hearing from you today. And we hope that you're feeling better and you're able to join us, full-heartedly today. So a very warm welcome to you too. And so these are our list of participants for today. And the format will be the same as the first session. So each presenter will be given 10 minutes to complete their presentation, and we will follow that up with a few minutes of feedback and discussion from our esteemed faculty. No audience questions will be taken up. And at the end of the session, I'll give the hand over the session back to Dr. Parthav. So if Dr. Isha is ready, can we start?
Yes, I'll just share my slides.
So Dr. Isha, she's joining us from Guru Nanak Eye Center, Delhi. And she will be speaking to us on imaging recommendations by the MUD Task Force for Non-Infectious Posterior Uveitis, Interpretations and Perspectives.
So,
over to you, Dr. Isha.
Yeah, are my slides visible?
Yes, your slides are visible.
Okay. So, I'd start now without any further ado. Good morning, everyone. I'm Dr. Isha, and I'll be talking about the imaging recommendations by the Multimodal Imaging Uveitis Imaging Task Force for non-infectious posterior uveitis. And I'll be adding a little bit of my own interpretations and perspective to it. Yeah, these are the abbreviations that I have used in the slides that come further. Now, what was the purpose exactly for the MUV task force to generate such massive amounts of reports on white dot syndromes or non-infectious posterior uveitis, as we now call them? As you can see in the images below, that there are white dots which are distributed kind of similarly in all the three images that we can see. So there was a lot of diagnostic uncertainty before these reports came in. We did not even know what imaging to use, what to interpret out of those imagings, and what was the sequence of how to image these dots. And there was no consistency on how we could use the imaging modalities, despite there being a big armamentarium of imaging modalities that were present. Also, the Sun classification did not cover the gap. It did give you classification criteria, but there was nothing on the imaging modalities that could be used. So with that purpose, the MUV task force came up with standardized guidelines to diagnose non-infectious posterior uveitis and also released a set of minimal imaging sets which could help with the diagnosis, help us differentiate active from inactive lesions, monitor the disease activity as well as the complications. Now, this study was conducted in multiple phases and 9 reports were released. It is going to be very overwhelming if I start to cover each report, like report by report, number by number. So I'll just tell a gist of it that reports 1 to 3 majorly focused on the survey methodology and systematic review that they conducted. Reports 4 to 8 were more disease specific. These were basically the consensus imaging guidelines and also the minimal imaging sets that could be used for that particular disease. Report 9 focused on validation of these minimal imaging sets. But again, focusing on all 9 is not going to be the topic of discussion today. And I would like to more focus on how do we differentiate these lookalike dots and when is non-imaging enough and when do we need to actually inject the patient with a dye to diagnose a particular condition. Now, coming to the first part, that is differentiating the lookalike white dots. In the first one, we can see that all these, again, if you see these images, there are just dots which are just, spread either in the posterior pole, slightly in the periphery or elsewhere. But they all kind of look very similar, just if we want to see it on a color fundus photograph. For some conditions, the color fundus photograph may be enough, but for others, you need to have more pattern-specific approach. You have to add layers of imaging to it. So this is my approach. So when I look at some white dots which are present on the fundus, I would focus on one, which is laterality. Second is the location and size of those lesions. And third is the layer. Location, laterality, we can very well see on the color fundus photograph, but for layer, we have to add more layers of imaging. For laterality, if it's a unilateral lesion, more often than not, it is most likely going to be a Mude's condition. For the location, if there's a posterior pole involvement, a small lesion, it's most likely going to be a PIC lesion. Similarly, a posterior pole lesion with variable size white dots ranging from 100 to 2000 microns, it could be an AMPI. Predominantly nasal involvement with white dots ranging from 250 to 500 microns and slightly orangish in nature because these are deep. These lesions are most likely to be birdshot chorioretinopathy. Now, for the layers, we know theoretically that superficially it is AMPI and Mude's, and deep involvement is seen in serpiginous, multifocal choroiditis, PIC lesions, or birdshot. But again, as I said, to figure out which layer is exactly involved, what is the level of activity, we have to have more imaging that is required. Now, first of all, when we want to go for imaging, we would not directly jump to invasive modalities, and not all of us have the option to do invasive imaging as well. So for that, the first step would be non-invasive. And can non-invasive imaging per se be enough? Yes, they can. Just color fundus photographs based on the MUV imaging sets. If we see this kind of a photograph where there is a serpentine lesion which is confluent, it is radiating from the disc present currently at the posterior pole, but it could be involving the mid-periphery or periphery. This is more likely to be a serpiginous choroiditis. Now, these lesions, although the dots look similar, the distribution, as I said, is different. Multifocal choroiditis is more in the mid-periphery. The lesions are larger. And PIC lesions are confined to the posterior pole, and these are smaller lesions, less than 250 microns. Now, but can we diagnose these? These are very lookalike. It's very difficult to diagnose these conditions just on the basis of a colored fundus photograph. So here we'll add a layer of non-invasive to it. So unilateral faint spots, centrifugal or centered through the posterior pole, If you do a high mag, you might be able to see foveal granularity. You add a layer of non-invasive, which is a fundus autofluorescence, and you see a hyper autofluorescent lesion, which suggests activity. And then you add another layer of non-invasive, which is OCT, and you see that there is ellipsoid zone or inner zone disruptions. This is most likely a Mude's disease. Now we go to another one, similar looking lesions, paucifocal, multifocal, slightly deep yellow, variable size, and located primarily at the posterior pole. Now we do one layer, which is OCT, and we see hyperreflectivity, which has gone beyond just the EZ, layer. It's involving the outer retina. There is external limiting membrane involvement, outer nuclear layer involvement. And if you also see subretinal fluid in a bacillary layer detachment, you're most likely dealing with an AMPI. But is this enough as per the MUV task force? No, not really. You have to add, inject the patient, do an FFA and an ICG, and you can see that there is early hypo lesions on FA and ICG both, which become late hypo or there's late pooling on FA, and they remain persistently hypo on the ICG. So this is what AMPI looks like. Now, another condition which is not really seen very often in India is these orangish lesions which are radiating from the disc, present more nasally. You add a layer of FA to it, you see that there is vascular leak, there's disc leakage, and there's late hyperfluorescence at the margins of these active lesions. And when you do an ICG, you see a diffuse multi-early hyperfluorescence, which is way more than what you could probably see on the colored fundus photograph. So this tells you that this is birdshot chorioretinopathy. Now, for the diagnosis per se, what we realized on reading all these reports is that for serpiginous or multifocal choroiditis and for PIC lesions, these can be very well diagnosed clinically based on just the color fundus photograph, and you need not require any other imaging for it, for just the diagnosis. But for birdshot and AMPI, you require invasive imaging tools to guide your diagnosis. Then the next layer to the MUV task force was to monitor disease activity. For serpiginous, it is very well known that you can do a autofluorescence. And if there are hyperautofluorescent edges, you know that the lesion is active. If these are hypo, these are inactive lesions. Now, similarly for Mudes, if the lesions are hypo as seen on FA, these are going to be active lesions. And progressively, you can see that through the stages, they become hypo when they're resolving or healed. If you do an OCT through that, you'll see puff balls, again, ellipsoid zone, interdigiting zone disruptions that you can see on the OCT, which resolve very beautifully if you can see on the other right image, that these do not leave any, there are no scars or there's nothing that's visible once the lesions are healed. Now, for activity monitoring in multifocal and PIC, OCT alone is enough. You can see these fluffy subretinal homogeneous lesions that can be seen when the lesions are active with ellipsoid zone disruption, focal choroidal, underlying choroidal thickening. And when the lesions resolve, there's nothing that remains. Those fluffy lesions disappear. There might just be some focal disruption of the ellipsoid zone, and you might or might not be able to see choroidal excavation. For AMPI per se, as we saw, that OCT involves certain more layers of the outer retina, along with SRF or a presence of a bacillary layer detachment. And when you image these lesions on an octa, there'll be flow deficit areas in the active lesions. For birdshot, again, you have to be a little more invasive. As we said, that there could be vascular leak, late hyperreflectivity, and disc leak on the fundus fluorescein angiography. The healed lesions might show transmission defects and staining of healed lesions. The early hypos that we could see on ICGA might transmit into choroidal atrophy on the healed lesions of the ICGA. It might not show much, OCT might not show much on the, for birdshot chorioretinopathy, but the healed lesions will actually be, there'll be a lot of thinning and atrophy which will be visualized on the OCT. Now, for disease activity, what they recommended was that for everything except birdshot chorioretinopathy, non-invasive imaging tools were sufficient for the activity monitoring. For complications, what was seen in those 5-6 reports that talked about disease-specific consensus, only multifocal choroiditis or PIC lesions and serpiginous choroiditis required monitoring for complications, which could be very well done with OCT or OCT angiography, where you could detect CNVs as an abnormal vascular network with a flow signal. So for complications per se, none except serpiginous choroiditis or multifocal choroiditis or PIC required any monitoring. And for that also, non-invasive modalities like OCT and OCT angio were enough. Now, this is the gist of the validation that they did with the minimal imaging sets that they recommended. And we've mostly discussed that in all our previous slides, that for serpiginous multifocal PIC, diagnosis is made very well by just the color fundus photograph. You can add OCT and FA to it, but that's more required for monitoring than anything else.
That's your time up.
Okay, I'm just at the summary. Yeah. So the strengths of the MUV is that there are clear imaging fingerprints, there's reduced ambiguity, there are definite activity markers. And the way forward would be a cost-benefit analysis, resource-tiered graded sets, and data sets for other white dot entities as well. With that, I would like to end my presentation. And I would like to thank
you.
LVP and Uveitis Society of India for the opportunity.
Thanks a lot, Dr. Isha. I think it was a wonderful start to our day. And with that, I would like to invite comments from our faculty. Dr. Amol Gupta, sir.
I think Isha did a great job, showing some fantastic images. And I think it's a vast subject, and she tried to cover, the subject in the limited time given to her. And I would have personally preferred if she had gone a little slower for the non-initiated attendees in this meeting. I would suggest all the presenters to please acknowledge if these images belong to you, you need not, acknowledge yourself, but if they are borrowed from either from literature or some other, it will be a good idea to develop this habit right now. But overall, I'm very happy with the presentation. Thank you.
Thank you, sir. The images were mostly from the reports itself, and I'd mentioned the reports in the slides below.
Thank you, sir. Dr. Neri, can we
Well, congratulations. I mean, it's never easy. I mean, I come from a university that based, its research and development back in the days from Ancona, working with Larry Iannuzzi, that was one of the advocates for ICGA and imaging. So it's a topic that I really care a lot. I agree with Professor Ahmad, having to let's say the goal to cover such a big amount of informations. I would have crafted the presentation a little bit more focused, since when you have a very vast, and very diversified kind of diseases to be presented, it's better that you present the philosophy of the initiative, so why the initiative has been done. Number two, there are a few things that you need to acknowledge. Is that it's true that it's an initiative that is involving, a vast number of experts. However, there are some research groups that are in disagreement with most of the terminology that you presented. For example, PIC and other, kind of diseases you presented are no more used in the fashion that you said. For example, there are those who created the name PIC, or those who contributed to write literature. In 2014, they wrote an editorial, including Lee Jane Paul, that called all this terminologies idiopathic multifocal choroiditis. And this is one of the things that were not addressed in the MAV report. And I can tell you that I'm proud to tell that I'm part of it for some of the diseases that were discussed. Now, when you want to reach the consensus, maybe everything that you bring is not acknowledged universally, but the intent of the MUV report is to try to bring clarity and have a step forward to try to have a methodology that might be not universally accepted, but can simplify the life of those who are not uveitis professionals. That's, I think, was one of the things that I missed in your presentation, but this is just one of the few things that you might have mentioned, but the job was amazing. Congratulations.
Thank you.
Thank you, Dr. Neri. Dr. Reena, are you online?
Yes.
Can we have some comments from you, please, ma'am?
Yes, thank you. Dr. Isha, I think you're doing a great job. It's a very well structured and insightful presentation, especially for those ophthalmologists out there who wants to be able to differentiate the white dots syndrome and in uveitis, posterior uveitis. But I have the shared feeling with Dr. Neri that this is for ophthalmologists, the one that is practice ophthalmology. It would be nice if you are highlighting the clinical consequences at the beginning, and then maybe add a bit about pathophysiology that can explain why these diseases are different in the imaging, and make it as an anchor throughout your presentation, and then summarize again at the end. So I know you already selected a few of these cases, but maybe in a 10 minutes time, you should select the one that is really can anchor how people think, and then just choose to present that one. So you are not in a hurry, and then maybe people will get the message across a little bit better. Because I always say a presenter is like a cook. So you're cooking something, and maybe you want to give them just little piece that they can bite and take home the message. Thank you, Dr. Arshi.
Thank you for that excellent point, Dr. Reena. Dr. Rohan, sir, can we hear from you, please?
Yeah, Dr. Isha, a nice presentation and definitely not an easy task. You had definitely a lot of reports to cover, but I like the point that you also added your perspective to it. So it was overall a very good presentation. But for the other listeners and all, just to add a few points and something what Dr. Neri said, what is the philosophy behind it? So just to add my take to that, so if you go way back in time, initially many of these have been described by Gass himself, and if you read the textbook of Gass, he says that uveitis specialists, there are two groups. One group would be called clubbers, who would like to club everything and call everything idiopathic uveitis, like Dr. Neri mentioned, and would not like to differentiate much. Whereas he himself belongs to the other group, where he would study the histopathology and detailed clinical findings and try to separate each entity so that each can have a different prognosis and a different set of features and maybe different treatment also in future. So that was the attempt to differentiate these various categories. And my generation and the generation senior to me, all of us are so lucky that the multimodal imaging in really developed during our time. And many of our authors, if you see the initial papers, would be that we have been describing multimodal imaging in all these conditions and trying to describe them better and better. And now these reports come which try to say that you don't need all that multimodal imaging for everything, but rather be very specific and targeted, and yet you will be able to differentiate these conditions. So that is probably, in my mind, the most important thing about these reports. Overall, a very nice presentation. Thank you. Thank you.
Thank you.
Thank you, Dr. Isha. And I think now we can invite our next speaker. So Dr. Molly Shah, she is joining us from Ahmedabad, and she will be speaking to us on silent sight thieves, pediatric uveitis GPS to vision preservation. Over to you, Molly.
Good morning, everyone. Are my slides visible?
Yes, we can see.
Okay. I would like to thank Uveitis Society of India for giving me this opportunity to present on this platform. And today's my topic is silent sight thieves, pediatric uveitis, GPS to vision preservation. So why I chose 1 minute. My slides are not moving. So why I chose this topic? Because treating pediatric uveitis is like a maze of roads. To reach destination, we need the right path. In our case, clinical and scientific evidence to reach the diagnosis. As we all know that it is a silent threat, and it is among the 16% of the total uveitis cases. One of the study from India showed that 8% of the affected eyes already had severe visual impairment at the time of presentation, and another study from India showed that 20% progressed to blindness despite therapy. So, what makes children so vulnerable? They have poor symptom reporting. children lack vocabulary to describe visual symptoms. They have gradual adaptation to the less vision, so slow progression allows neural adaptation. They have amblyopia masking, suppression of affected eye hides vision loss, and in case of bilateral disease, there is no comparison point when both the eyes are affected. So it is a silent inflammation causing permanent damage in children. Let's navigate to vision preservation. So I have divided this topic into 4 checkpoints. First is pattern recognition, second is examination, third is investigation, and the fourth one is treatment. Let's start with pattern recognition. This was a 8-year-old female. She was referred by a rheumatologist to us, and she had complaint of joint pain and swelling in right knee. She was diagnosed with arthritis, and when she presented to us, she had no complaint of pain or redness of the eye. On examination, we could see that it was white eye with non-granulomatous anterior uveitis having posterior synechiae. Posterior segment findings were unremarkable in this case. So this was a case of JIA related anterior uveitis. As we all know that JIA related anterior uveitis is the most common cause of non-infectious uveitis in children. So we should know that risk of developing JIA uveitis is divided into 4. We should consider 4 things to check for the screening. One is category of arthritis, ANA positivity, JIA onset, and duration of JIA. But according to US and UK guidelines, screening of uveitis in all the JIA patients should be done every 2 months for the first 6 months after the onset of JIA, and then every 3 to 4 months till it is recommended by a rheumatologist. Coming to another case, this was a 5-year-old male presented to us with diminution of vision in both eye for 1 week. On examination, he had bilateral granulomatous anterior uveitis. Posterior segments findings were unremarkable. On systemic examination, he had swelling of the interphalangeal joint, that is arthritis, and and rash over the chest area. So considering this is a classical triad of Blau syndrome, we investigated, and his ANA, RA, ANA, MON2 were negative. So this was a case of Blau syndrome. Coming to another case, 13-year-old girl presented to us with diminution of vision in left eye for 8 days, and she had contact with pets. So on examination, left eye had focal retinitis involving the macula, and other eye also showed old pigmented patch superior to temporal to the macula. And we did OCT and we could see that it was a retinochoroiditis. So this was a classical case of toxoplasma retinochoroiditis. So pattern recognition is important with clinical and systemic signs. But beware of masquerade in all the pediatric uveitis cases. When there is atypical presentation, or we are having poor response to conventional therapy, or the uveitis is worsening despite treatment. So there are few most common masquerade in pediatric age group like leukemia, retinoblastoma, end of. So one should consider masquerade while making the diagnosis also. Coming to the examination part, I have simplified it into a mnemonic vision. So try to comfort first, verify comfort, try to build rapport with the child. Inspect with dilatation, don't fight small pupils, always dilate and see. You can take help of scan, that is ultra wide field imaging like Optos. Always check intraocular pressure on each visit. Try to offer steroid sparing plan and never miss follow-ups. So coming to the investigation panel, we should divide it into 2 parts, ocular imaging and systemic investigations. So we can take help of ultra wide field imaging, OCT, FFA, B-scan and UBM to make the diagnosis. And also systemic investigations should have tailored approach. Basic workup should be done in all the children to check for the health status of the child and before starting any immunosuppressive therapy, and followed by targeted investigations should be done based on positive history, clinical pattern and systemic examination, and also consider family history while doing systemic examination, and when in doubt, try to collaborate with rheumatologist, pediatrician, or ID specialist. But don't ask for uveitis profile to all the children. For example, if a child is presenting with anterior uveitis, which is non-granulomatous, and patient is also having arthritis, then we should suspect JIA and ask investigation like ANA specifically to JIA. Coming to the treatment part, for acute cases, steroid is the treatment, but try to escalate as soon as possible. Aim to stop steroid by minimum time and shift the patient to another therapy like immunosuppressives or biologics. Prefer IV bolus instead of oral in case of recurrences, and please keep in mind that always do intraocular pressure monitoring on each visit because chances of steroid response are there in children. Immunosuppressants are nowadays first line of management, and we should start on the day one with the steroid in case of non-infectious uveitis. Methotrexate, mycophenolate are most commonly used nowadays. Try to give a combination therapy with biologics or another immunosuppressive, and subcutaneous route is preferred for the better efficacy when oral is not tolerated by the child. And communicate clearly with the rheumatologist about your aggressive vision saving treatment approach. Coming to the biologics, nowadays early initiation of biologics is preferred in non-infectious cases which are refractory to IMT, and options available and which are most commonly used are adalimumab, infliximab, and JAK inhibitors, and refractory cases tocilizumab. So we should have multidisciplinary approach while treating pediatric uveitis. Try to coordinate with rheumatologist, ID specialist, pediatrician, and dermatologist, and also consider family education and support so that we can preserve child's childhood and growth. Always consider monitoring and follow-ups. So monitoring frequency should be tailored according to disease activity, treatment intensity, and individual risk factors. We should keep some red flags in our mind which requires immediate attention on follow-ups like glaucoma, complicated cataract, cystoid macular edema, inflammatory CNVM, amblyopia. And I would like to conclude my presentation that if we can fight this pediatric uveitis battle with 3 P's. First is patient, second is parents, and third is physician. So screen systemically, examine thoroughly, test smartly, treat early, and monitor lifelong. Because every systemic step saves sight, every screening prevents blindness, and every early escalation preserves childhood. Thank you.
Thank you very much, Molly. That was a wonderful presentation. You finished well within time. Thank you for that. So, Dr. Neri, can we have some comments from you, please?
Sure, absolutely. Well, you covered a very, very tough topic, and pediatric uveitis are apparently, for those who are non-uveitis specialists, a threat, but it's not like that. So I wrote 2 chapters about pediatric uveitis back in the days, one for an American book and another one for an Italian book. And there's one thing that you didn't disclose in the presentation that I would encourage you for next time. Uveitis cases in pediatrics are very, very, very limited. JIA covers up, most of the cases, and you got Blau syndrome that, belongs to the NOT card expression of one of the rarest diseases. You can't see it when you see granulomatous uveitis, but toxoplasmosis and JIA are the real deal. All the others are extremely rare, are extremely bad. I would encourage you to use a verbatim when you present that is less categoric, because you said I would use a pulse to set a recurrence. I think I never pulsed a kid unless I had a pediatric batchet or the very nasty onset of VKH. So those are things when you deliver a message that can convince those who are not into uveitis to do so, which is not correct. You had a potpourri of diseases, and citing what Rohan said before, There are groups that try to create clusters and groups that try to make multiple differentiation. This is true in many different diseases. In pediatric uveitis, you need to dissect. And also when you stated that IL-6 can be an option, just remember that IL-6 has been proven to be non-effective in cases refractory to anti-TNF-alpha agents in pediatric uveitis. So those are things that when you present might be lost by most, but if there's someone that noticed that, then you have to justify why you say that, and then you put on spot. So since you're very young, I do believe that this is a good exercise for you to try to understand on how to refine your presentation when you present something that has such a vast field, but in reality, there are very few that are the true enemies in the daily practice. But congratulations. I mean, you did a great job.
Thank you, sir.
Thank you, Dr. Neri. Dr. Ramod Gupta, sir.
Yeah, I think Dr. Neri made a point, one, it's a very difficult subject to choose, and it's a very, very comprehensive. It's almost like covering an entire book on pediatric uveitis. And Molly, I would have preferred if you focused on, say, juvenile idiopathic arthritis associated uveitis, and given some new insight into the diagnosis, who are the patients with red flags who are likely to recur, who are likely to till what time are we going to monitor all these patients of JIA, starting what age, and what is the significance of ANA positivity or negativity, what is the significance of rheumatoid factor positivity, and deforming arthritis, non-deforming arthritis, and so I think you could have covered beautifully well one area or of say the most important which we feel which is the cause of blindness. uh, you know uh, Same is like you have spread yourself very, very thin, and just touching upon some of the key aspects, missing out on the details of one single entity. If you had taken up, okay, we would have, anybody who's getting initiated in uveitis would have probably learned a lot. But an overview, yes, sure, I would have given you 1 hour or maybe 90 minutes to cover the entire subject of. It's the subject of a full seminar rather than, in 10 minutes. So when you're selecting subjects, I would suggest that you develop a focus on one particular aspect rather than try to cover everything. Well, otherwise, for a 90 minutes lecture, I think it's outstanding compilation of material. Thank you.
Thank you, sir.
Thank you, sir. Dr. Reena, would you like to weigh in, please?
Yes, thank you, Dr. Ashi. So, Dr. Mauli, I think you already done a great job. I know you are trying to understand pediatric uveitis and try to share how you see it, and you really organized the talk around a clear framework. I can see the pattern recognition, examination, investigation, and treatment, and you bring home messages for the audience to understand the vision mnemonic. I think you have a very good teaching instead. Despite the limited time, you managed to highlight the essential red flags and everything. I know, but this is a very tough presentation, and you did it less than the time you needed. So you did it at 9 minutes. I would suggest to use the last minute probably to have just one frequent case, like Prof. Neri said, using DIA or toxoplasma to anchor the framework that you have in one case. So people can see how to approach. So at the beginning, you already see, so you already shown several short case, but maybe with those framework, you repeat again at the last using your suggestion on how to see the pediatric uveitis. But overall, your delivery was very calm, clear, and very pedagogical. I mean, you are trying to teach the audience for a pediatric uveitis. Very well done. Thank you.
Thank you, ma'am. Thank you.
Thank you, Dr. Reena. And we'll have some concluding comments from Dr. Rohan, please.
Yeah, so everyone else has already told you, you had a very systematic presentation. That's nice. But again, yes, the few important points when I would like to talk on pediatric uveitis, I would definitely like to stress a little more now on these newer drugs and tell the audience when to use them, what are the precautions before using them, and some of the results of the recent studies which have advocated these drugs. And another point I would like to probably touch is cataract, because that is a big issue in pediatric uveitis. So there are controversies in it, but yes, you should give some important messages regarding cataract management. Thank you.
Yes, sir. Thank you.
Thank you, Dr. Molly. I think you got wonderful points to add to your presentation and, have a more focused presentation probably at a next meeting. So
Yes.
thank you, Molly. And with that, I would like to invite our next speaker for the day, Dr. Meera Mohan Kumar. So she is joining us from Arvind Eye Hospital, Coimbatore, and she will be speaking on a guide to common management errors in anterior uveitis. Dr. Meera, would you like to share your presentation
ma'am.
with us,
Yes,
please?
ma'am.
Yes.
Yes.
Please.
Good morning, respected members of the faculty. I hope my slides are visible.
Yes.
So today I'll be, yes, thank you, ma'am. So today I'll be talking about anterior uveitis and avoiding common management errors. All the clinical images that I have used in this presentation has been exclusively documented by our department at Arvind Eye Hospitals. So where all can we go wrong? We can make mistakes in our clinical diagnosis, we can make mistakes in management, and complications can arise due to our mismanagement. So what are the few challenges that we can face? All the patients coming with anterior uveitis usually have a lot of photophobia. They can come in and give us a very incomplete history. And pediatric patients, as mentioned before, they can be uncooperative, and getting a clinical diagnosis will be difficult in these patients. So these are the few challenges that we can face. So the first question that we have to ask is it only anterior uveitis? So let us identify what is the primary focus of inflammation. So is it something that starts in the anterior segment and goes to the posterior segment, or is it something that has started in the posterior segment and has spilled over to the anterior segment? So my slides are not moving. Yes, dilate, dilate, dilate. So anterior uveitis does not preclude other pathologies. So all our patients should be dilated. So if we cannot see enough of our posterior segment because of cyanic A, we have to get an ultrasound or even a fundus photo that help us to reveal peripheral pathologies. So now clinically approaching the differentials. So here we have a patient who came to us with coalesced granulomatous keratic precipitates and very obvious signs of anterior segment inflammation. Had we not dilated and seen the fundus, we would have missed this very obvious headlight in the fog appearance of ocular toxoplasmosis. Here is another case who presented to us with, stromal haze, a festooned pupil, and a complicated cataract. Had we just examined the anterior segment, we would have missed this very evident solitary choroidal tubercle in the posterior pole. This was actually a case of ocular tuberculosis, and we would have had delays in starting ATT. So it is not enough if we just examine the posterior pole. It is also important that we see the periphery, the retinal periphery, or we can miss something as fulminating as this, an acute retinal necrosis, especially in cases of viral uveitis. Now, again, coming to another example. So you see this patient, very evidently, you have signs of anterior segment inflammation, posterior cyanic A, congestion. But on retracting the lid, what do we see? Here we can actually see a trace hyperpion. So it is very important to retract the lid and examine thoroughly. They can actually give us hidden clues to diagnosis, like this trace hyperpion. It could be a case of HLA-B27, it can be Behçet's. So it is very important to examine in this manner. So even in a very white-looking eye, it does not mean that there can be no inflammation. Look carefully for signs like this trace hypopion. So even in a white-eyed presentation, look for obvious clues that can help us in diagnosis. So if it is a granulomatous anterior uveitis, is it tuberculous with a granuloma in the anterior chamber, or is it something as morbid as this? Is it a very mutton fat granulomatous keratic precipitates of sarcoid? Or, in lepromatous leprosy, we have peripheral anterior synechiae and very iris atrophic patches. So it is not just about your anterior segment examination. It is supplemented along with your physical examination. So you can see in the first two images, it is very obviously supporting a diagnosis of leprosy. Again, our ancillary testing for it may be a positive Manto testing for tuberculosis or chest radiographs for tuberculosis. So all this together helps us in coming to a final diagnosis. It can also be a part of a pan-uveitis, as in Vogt-Koyanagi-Harada or sympathetic ophthalmia. Again, I would like to stress upon the fact that the posterior segment needs to be examined to make out whether it is in the acute phase where you have exudative retinal detachments, whether there is a sunset glow in the chronic phase of VKH, supplemented again by physical examination signs like vitiligo, poliosis in case of VKH. Now, when the patient comes to you like this, you have a very evident corneal scar, you have multiple iris atrophic patches, and you have a D-shaped pupil, the diagnosis is very evident when the physical features are, suggestive of herpes zoster ophthalmicus. Suppose you don't have this clinical signs, these anterior segment features should help you to suspect anterior uveitis. So the other main component is a raised intraocular pressure. So the two P's I would suggest in viral anterior uveitis would be pigments and pressure, where you have pigment dispersion, atrophic patches, pigmented KPs, and a raised IOP. Now, when you have a very severe congested looking eye, a very thick fibrin membrane in the anterior chamber, and a complicated cataract, it can either be unilateral, bilateral, a pinpoint presentation. The patient is giving you a history of inflammatory joint pain along with something that looks like this. Should not forget to test for HLA-B27, and this very clearly looks like a case of ankylosing spondylitis. Now, like my previous presenter mentioned, this is a very white-eyed looking presentation. This was a child who came to us, but in a very late stage. You have a band-shaped keratopathy, you have a complicated cataract. Just because it's white-eyed does not mean that there is no inflammation. Rule out juvenile idiopathic arthritis, especially in the pediatric age group, and initiate treatment early. Now, what are the things that can mimic anterior uveitis? So this was a case that was treated in multiple places with topical steroids, non-resolving, and came to us. On closer examination, this is what we saw. We saw through and through wound. And on gonioscopy, this is what we saw again. So you have a foreign body sitting in the angle. So even cases of cirrhosis bulbi can mimic anterior uveitis. So we have to take care. Don't get misled by the pigments in pigmentary glaucoma and pseudoexfoliation glaucoma and treat it as anterior uveitis. These are the other differentials to be kept in mind. Now, what are the other things that can mimic uveitis? Is it secondary to a drug-induced reaction? Is it a masquerade, more fulminant, with less inflammation, large cells aggregates, a lumpy, bumpy hypopyon with inadequate response to steroids? Also, let us rule out other causes of red eyes that we face in our clinic, like scleritis, keratitis, and conjunctivitis. So what are the management errors that we can make? We have to treat aggressively. So when you treat a patient with inflammation, severe, hit hard with potent steroids like prednisolone, try to avoid a steroid antibiotic combination, taper slowly over weeks. Abrupt weaning is usually a trigger for reactivation. Don't hesitate to add cycloplegics. It helps in controlling pain, helps to prevent posterior synechiae, and don't keep the patients on long-term cycloplegics. They work usually only if the addition is fresh. As we all know, avoid using cyclopentolate as a cycloplegic because of its well-known pro-inflammatory action, and it's also a neutrophil chemotactic. One more point is not to let the inflammation worsen just to keep the IOP acceptable. So hit hard with potent steroids. We have to understand there is no standard workup for all uveitis patients. So when we order diagnostic tests, make sure that the results help us in our management. They should help us to rule in or rule out a disease. So in our population, TB is a very ubiquitous disease. It can coexist with everything. So we have to rule out infections before we commence systemic steroids. Don't treat only on the basis of blood or ocular investigations alone. So as I mentioned before with all the images, we have to treat on the basis of clinical impressions supplemented by a blood test. So a positive Manto may not be an indication to start ATT in all patients with recurrent anterior uveitis. So when you have posterior segment manifestations, again, as mentioned before, avoid using only topical therapy to treat the patient. Initiate oral steroids after ruling out underlying infections. In GIA uveitis, do not undertreat the anterior segment disease, even if the visual acuity is good or if it's a white-eyed presentation. Otherwise, you can end up with something as deleterious as this, advanced band-shaped keratopathy, complicated cataract. This is not something that you would want in a pediatric population. Glaucoma as a comorbidity is present in about 10% of the uveitis patients. We have to understand that every patient with uveitis is not a steroid responder. We have to check the other mechanisms. So you check the angles for peripheral anterior synechiae. In viral anterior uveitis, where patients present with a raised IOP and pigmented KPs, trabeculitis is actually the main mechanism. So we have to manage and treat accordingly. So I would just like to summarize my talk. So mainly we have to examine completely, not just with a slit lamp. We need a dilated fundus, not just to see the posterior pole, but also we have to see a periphery. We have to use imaging when required to see the unseen portion of the eye, as it can give us clues to clinical diagnosis. We treat aggressively, especially in the pediatric age group, to avoid visual morbidity and complications. In chronic and recurrent anterior uveitis, investigate, rule out any underlying systemic diseases, and initiate early immunosuppression in relevant cases to avoid visual morbidity. Thank you. I would also like to thank my mentor and teacher, Dr. Anuradha ma'am, for impressing upon me the basics of clinical examination. Thank you so much.
Thank you so much, Dr. Meera. I think that was a wonderful overview of anterior uveitis. You also managed to finish it within time. Thank you for that. So can we have some comments from Dr. Amod Gupta, sir, please?
Well, Dr. Meera, you did an outstanding job in not only selecting appropriate subject, but by and large, you covered all the errors people make when they are mistaking a pan-uveitis or a posterior uveitis for an anterior uveitis and try to treat it with local steroids. You emphasized very nicely the complete ocular examination before you make any diagnosis, that be anterior, intermediate, or pan-uveitis or posterior uveitis. So do not, it requires a complete ocular examination, including ultrasonography. That's a very good point that you made. And I think you presented at absolutely fantastic pace for everybody to imbibe what you were saying, give enough time to imbibe all that information, and you restricted yourself to the subject at hand and did not go astray and try to cover everything about uveitis. I would label this as an outstanding presentation, Dr. Meera.
Thank you, sir. Thank you so much.
Yeah.
I think that will make Dr. Meera's day today. Thank you for those wonderful comments, sir. Can we have some comments from Dr. Neri, please?
Sure. So, Dr. Menon, I want to explain what you did. I wish to bring gymnastics as an example. So when you look at the Olympic Games, you got, some exercises with a low score, okay, in terms of difficulty, which is based on how much risks you take. So the topic that you've chosen, it's a low risk topic. However, when you judge something, you give the score to the performance, and your performance was outstanding. When you present, you should do that job. So sometimes, you can choose the topics, but the art of presenting something is to be on point, to be on time, and to be meaningful. When I listen to your presentation has zero flaws. That's it.
Thank you, sir. Thank you so much, sir.
Thank you, Dr. Neri. That is another feather in her cap for the day.
Thank you.
Dr. Rohan, sir, can we hear from you?
So already she has got such nice comments, and definitely her presentation was very nice. She has nicely described all the common errors you can make and the most important thing of dilating the pupil and seeing the posterior segment. So I just want to add one more thing what my mentor Dr. Garg used to say. Dilating the pupil is not just for the posterior segment, which is of course very important like you said, but it is part of the management itself. You need a dilated pupil and a mobile pupil If he used to tell us that if you see a patient with synechiae developing, your patient of uveitis, then you have not treated the patient properly. The patient must go with a nicely dilated pupil. You don't send him before the pupil dilates. So that part I just want to stress upon, and otherwise you have made a very nice presentation. Thank you. Thank you.
Thank you, sir. Dr. Reena, can you give us some concluding comments for Dr. Meera's presentation?
Yeah, I think I agree with all the other judges. It is really a very enjoyable presentation. I can see that you already have experience, and then you mix with the theoretical literature, and you managed to assembling it right. Like Prof. Neri said, it's like gymnastic. You are debating this easy topic, but with a beautiful movement, but maybe another addition, because you have a little bit time at the end. Instead of giving the 4 points of summary, you can probably redo again what you did, because you are jumping around, but it's very beautiful jumping. But then you explain again in a brief slide that this is what you already presented and this is the summary, because it is really nice. I like it. I really enjoyed the presentation.
Thank you, ma'am.
Thank you, Dr. Reena. So with that, we can now move on to our next presenter. Thank you, Dr. Meera. I would like
Thank
to
you,
invite Dr. Richa Pyare. She's joining us from Shroff Eye Center, Delhi. And she will be speaking to us on white dot syndromes, from fear, fascination, and frustration to frameworks of understanding. Over to you, Richa.
Thank you, ma'am. Good morning, everyone. I will be talking on the so-called white dot syndromes. So white dot syndromes actually represent some of the most confusing uveitic entities that I find I really struggle to remember. And my hope is by the end of my 10-minute talk, I'll be able to help in sorting out at least 4 of these entities in all of your heads as well. So let's start with an entity that I find the most confusing, which is birdshot chorioretinitis. Now, it is a severe bilateral, potentially blinding condition, which has independent and concomitant retinal and choroidal inflammation. Now, typically, patients with BSCR present with a long-standing history over months of symptoms suggesting retinal inflammation, which includes photopsia. Patients complain of scintillating lights. They have poor contrast sensitivity. They struggle to differentiate between colors. They have blurry vision. In this disease, when the patient presents to us, it's possible that the only findings there are initially are a moderate vitreous inflammation with some retinal vessels sheathing, cystoid macular edema. Now, the typical birdshot fundus lesions actually are areas of scarring that develop very late in the course of the disease and in inadequately or incompletely treated patients. So we have this typical symptomatology of the patient, and they've come into our clinic. We do a multimodal imaging suite for them. What do we find? FFA shows retinal vascular leak, typically around arcade veins, but it can be in any artery, vein, or capillaries. The ICJ shows evidence of stromal choroiditis, which is occult HDDs. OCT shows ellipsoid zone disruption and choroidal infiltration, which means thickening of choroid, and the vascular markings become imperfectly seen. Now, here it is important to understand what is the difference between sine qua non, or what is absolutely essential for diagnosis, versus what is typical for a lesion. So for birdshot, HLA-A29 positivity is sine qua non. Evidence of retinal inflammation and evidence of stromal choroiditis is sine qua non. Yellow, creamy, round-shaped birdshot fundus lesions, which actually are the white dot aspect of it, are actually considered late phase of the disease. And this is one of the goals of the treatment, in fact, is to avoid getting these birdshot fundus lesions. Now, what is the follow-up and management? As birdshot is potentially blinding, high-dose systemic steroids with additional immunosuppression is important. It is important to monitor for signs of activity. Of course, clinical signs of activity like monitoring the symptoms, monitoring clinical photo, OCT for CM, and new development of CME, etc. is important. But an annual FFA, ICG, ERG and visual field is very important for birdshot, because even an apparently quiet eye in birdshot can have
inflammation that is ongoing. So the irony, therefore, of including birdshot in white dot syndrome again is that the classically described so-called birdshot fundus lesions are actually to be avoided, the development of which needs to be completely avoided. And so now that we've taken one entity out of the white dot basket, let's move on to the next entity that I want to kind of target, which is PIC or punctate inner choroiditis. Now, pathology proposed for this is an inflammatory choriocapillaritis, which then leads to ischemia of the choriocapillaris and then secondarily affects the photoreceptors. The classical clinical description is that of a young myopic female. She presents with yellow, small creamy lesions in the posterior pole, which then heal with scarring or with a punched out lesion and variable pigmentation. Patients of PIC actually are very sensitive to symptoms, and they notice paracentral scotomas, and they notice peripheral strobing lights. They have blurred vision. On examination, they will have almost no inflammation. Here again, I want to create a clinical spectrum. So PIC and multifocal choroiditis with pan-uveitis may or may not be part of a clinical spectrum. There is some evidence for and against it. But clinically, their lesions appear very similar. They behave very similar. They seem to have a common pathophysiology of inflammatory choriocapillaritis. There are a few key differences. One, the lesions of PIC are smaller. The lesions of MFCPU are larger. PIC is more clustered in the posterior pole. There is almost no inflammation. On the other hand, MFCPU lesions are clustered more peripherally, and they do have some inflammation associated with it. Now, the clinical lesions of PIC are very characteristic. The challenge here is not to really diagnose them, but to detect activity. OCT findings of hyperreflective fluffy Schrem, which with ellipsoid zone disruption, which goes beyond the margin of the Schrem, is very characteristic of activity. On healing, these Schrem lesions resolve, but the ellipsoid zone and RPE disruptions may persist. FAF uniformly autofluorescent lesions are active, uniformly hyperautofluorescent lesions are active, but these lesions with hyperfluorescent centers and a hyperfluorescent border are indeterminate. When it comes to trying to figure out neovascular activity again, if a patient presents with fresh symptoms, look for FAF, new hyperautofluorescence on FAF. On Octa, we can look for a neovascular network, but as MNV networks in PIC don't resolve even after treatment completely, it is important to look for signs such as an increase in network size. It is important to look for new tiny branches that develop. The bottom line here is that these are very subtle lesions, and serial imaging and documentation is key. And as patients are very sensitive symptomatically, we should use that as a guide to when we need to be more intense in our surveillance and scrutiny. So here, the sine qua non again of diagnosis is a typical clinical picture. The follow-up is challenging because the course is variable. All new inflammatory neovascular lesions do need to be treated. MNVs are, of course, treated with anti-VEGF, but there may be a role of combining this with anti-inflammatory treatment because it's theorized that neovascular activity is actually concomitant with active inflammation. There might be a role of immunosuppression also. Moving on to AMPI, this is also a primary inflammatory choriocapillariopathy, but the clinical phenotype is very distinct. There are placoid lesions over here. It was classically considered monophasic, but this has now been revised. Patients present with sudden blurring of central vision, paucity to multifocal creamy subretinal lesions are there. Both the OCT and FFA are very typical. The OCT shows hyperreflectivity of outer retinal layers going right up to the outer nuclear layer. The FFA shows early hypofluorescence, which is then staining in late phases. Early phases show more lesions. Both OCTA and the ICGA show choriocapillaris hypoperfusion. Now, how do we monitor for activity? OCT, the early hyperreflectivity resolves with a partial restoration of the outer retina with atrophic changes. Autofluorescence can change with the stage of the disease in AMPI. So AMPI can be diagnosed on the basis of choriocapillaris hypoperfusion in Octa and ICG, and a typical clinical imaging findings on FFA and OCT. Because the patient presentation again is variable, there is a role of systemic steroids as well as immunosuppression. In neuroimaging may be important, especially ask for patients' history for significant headaches, and any suspicion of neurological involvement means neuroimaging is essential. Moving on to the last entity we will cover, which is MUDES. Now, MUDES, the pathophysiology is still debated. It may be a primary photoreceptoritis, or it may be an example of inflammatory choriocapillaropathy leading to photoreceptor lesion. MUDES is classically unilateral. It is classically self-limiting. Presentation again with photopsia, central blurring. The fundus shows multiple gray spots with minimal vitreous inflammation. These gray spots resolve quickly and leave behind a foveal granularity. What is foveal granularity? It is nothing but that small yellow lesion in the center of the fovea. Again, imaging is very typical. It will show focal ellipsoid zone disruption with these tall pillars of hyperreflective material coming from the ellipsoid zone going right up to the outer retinal layer. FAF shows this dots on spots pattern, which is hyper intense AF dots on spots of hyper autofluorescence again. Imaging shows wreath-like lesions on FFA. Now, what are these wreath-like lesions? All of these terms are very frequently thrown around, but not really particularly understood. Wreath-like lesions are hypofluorescent centers surrounded by a wreath-like ring or of hyperfluorescence. Sine qua non, again, foveal granularity, wreath-like lesions on FFA, or those hyper-reflective lines of puffballs on OCT. It need not be unilateral and monophasic. As it is self-limited, treatment is not really required. Now, what is epimudes? Sorry, my slides are not moving, but to be succinct, epimudes basically is theorized to be mudes triggered in eyes with damaged choriocapillaris, Brooks, and RPE complex. They behave exactly like primary mudes, and they don't need treatment as well. To summarize, birdshot chorioretinopathy, retinal and stromal inflammation with a genetic basis, PIC and MFCPU, primary inflammatory choriocapillaropathy with clinical findings on a spectrum. Retinal subretinal fibrosis and MNVs are complications to watch out for. AMPI is choriocapillaris hypoperfusion with typical findings on OCT and FFA. MUDES may be photoreceptoritis, which is self-limited, can also present as an epiphenomenon in eyes with damaged CC Brooks and RP complex. Thank you.
Thank you, Richa. That was a very spirited discussion from you on the white dots. So can I invite some comments from Dr. Amod Gupta, sir, please?
Yeah, Archie, you rightly said it's a highly spirited presentation. Richa, you started with your title of your presentation was Fear, Fascination, Frustration, and Framework. I didn't see that in your selecting what was fearsome or what was fascinating about these four entities that you chose, or what was frustrating in the sense you spent a lot of time on birdshot chorioretinopathy, a disease which we hardly ever see because A29 is, practically non-existent in Indian population. And you might have chosen something we see very commonly. But, and what was finally the framework to slot the four chosen white dot syndromes in your presentation? I mean, how did we move from there, except for giving your description of each of these four? I think it didn't reveal any insight that you wish to share, how they were, how you fear them, or how are they fascinating, in what aspects. And frustration, yeah, to some extent, you did talk about that in managing birdshot chorioretinopathy, but others, I think, was not, except telling a review of literature on these four. So I hope you are more focused and be slow in presenting your material. Excellent slides, but need to be a little more slow than what you were. Yeah, thank you.
Thank you, sir.
Thank you, sir. Thank you. Dr. Reena, would you like to weigh in on Dr. Richa's presentation?
Yes, thank you. Congratulations, Dr. Richa. You already try your best to present a very difficult disease group and also very dense. And I also note how the title, I can get the frustration part, but we need to develop to the frameworks of understanding. So because you took a lot of disease, I think, like I said before, you need to be a cook for your presentation. So you need to choose the one that you would like to give to the audience. For instance, you grouping based on the imaging probably, or for certain kind of disease, but it is always good to anchor it to the clinical consequence. So by differentiating or doing the frameworks of understanding, you can differentiate these disease more. Or if you want to just take one disease first, and then maybe you need to take one frameworks first. So don't just present everything all at once, because at the end you are trying to fit the audience. And probably I would like to comment a bit about the slides, the choose of fonts, and also the choose of the size of the fonts consistently. It will help the audience. And for us ophthalmologists, we really like pictures. So giving many pictures and with minimal explanation, avoid the abbreviation. I saw you have a lot of abbreviation because you are trying to condense so many writings in one place, because you use the circle, the black circle, but then you're limiting yourself for the space for the fonts to be there. And there's a lot of different size of fonts and different kind of fonts. Maybe you have to be kinder to your audience, because presentation, the PowerPoint, is the tools for you in order to give away the understanding to the audience. So you're being kind by giving a very clear presentation, and use the PowerPoint as a way to make the people understand what you say, and anchoring and coordinating with what you are explaining. But overall, you have done a great effort to explain everything all at once. But maybe next time you choose just one topic or something. Yes.
Sure, ma'am. Thank you.
Rashid.
Thank you, Dr. Reena, for giving excellent tips. And I would like to invite Dr. Neri to give the concluding comments for this presentation, please.
Sure. I mean, Dr. Richa is a doctor that I appreciate. I had the chance to listen to her recently in Jammu when I came, invited speaker there, and I really appreciate what she does. So I dare to give you some suggestions about the content and how the way you present. So I echo what my colleague said. One quality that you have, and one thing that I would suggest to refine, is your enthusiasm and energy. And sometimes when you are over enthusiastic and you're over energetic, you can overwhelm the listener. And that's one of the things you need to work for. Because when you deliver and you get extremely energetic, sometimes you over present. And that's the problem of creating a presentation that, as Dr. Reena said, can be a pitch convincing the people that are in front of you. Second thing, which is another important aspect, you made some statements that I don't know if you did it intentionally, but I can tell you that there are scientific evidences. For example, you said that PIC and multifocal choroiditis with panuveitis may be not, the same spectrum of disease. Actually, 15 years ago, Andrew Dick and John Forrester from Aberdeen and Bristol have proven that they share the same haplotypes of TNF-alpha and IL-10. So that is the same disease with a different immune phenotype. These can have reflections on the decision making. And once again, I'm in total disagreement with the nomenclature of white dot syndrome, because it's just a potpourri of diseases. So it has been discussed. There are some groups that still are attached to that, but recently we had also the MUV that reclassified that. So white dot syndrome probably will never exist anymore, because to my opinion is a misnomer, but it's my personal opinion. Now, the point is that when you have multiple different diseases, the segregation of the methodologies for treatment, making statements telling, well, immune suppressive agents might be considered, it's not correct. They have to be considered. So when you have a multifocal uveitis with multifocal choroiditis, if it is a stromal choroiditis, you must immune suppress the patient. PIC can be less aggressive. You can have the chance, but to an expert like I consider you yourself, you should tell me why you're doing this. And I didn't really get it there, but I saw an overview of opinions of others while I would have expected your expert opinion. And I think that you are at that level. That's why I dare to tell you that.
Thank you, Dr. Neri. A lot of food for thought for her. And I would invite Dr. Rohan to give his comments also, please.
Yes, Dr. Richa, definitely a very, very enthusiastic presentation. But like everyone has said, probably you could have just limited to few things. And I would echo what Sir said. Why start with birdshot? Because in our country, definitely all of us might have rarely, a few cases only all of us would have seen. And again, just a few technical pointers like Dr. Neri pointed. Even in birdshot, I think you mentioned that the absence of spots also would make a diagnosis. But I think to my mind, the minimum diagnostic criteria is at least 3 spots, probably
No, sir,
more so nasal
not
sebaceous.
anymore. Even MUV says that birdshot fundus lesions are not required. And
Okay, probably you're right. So maybe I'm talking of little older criteria. But yes, so limit to the more important things and just the main. You could have put a slide of one disease and the OCT and the fundus or FFA of the other disease along with it to compare it, just to show that this happens in mutes, this happens in AMPI, to give a proper comparison rather than going one by one. So that might have helped the audience. Thank you. Thank you.
thank you, sir.
Thank you, Dr. Rohan. Thank you, Richa. We look forward to hearing from you soon. And with that, I would like to invite our next speaker, Dr. Sai Bhakti Mishra from Narayan Nethralaya, Bangalore. She will be speaking to us on the enigma of viral uveitis. Over to you, Dr. Sai Bhakti.
Am I audible and visible?
Yes, yes, you are.
Yeah. So, good morning, everybody. And I would like to thank the USI for this opportunity at the outset. And I will be speaking about the enigma of viral uveitis. Okay, again. So I will be limiting myself due to time constraints to the herpes viridae family, but this fortunately is a major chunk of our cases. I have structured my talk into 3 parts: the foundations and fundamentals. Just a minute. Start your video. Are my slides visible?
Yes, doctor. Please continue.
So the foundations and fundamentals, the real questions and the outliers. So this is the snapshot of the historical presentation, how the cases were reported. It started with mumps way back in 1882, and every few years, few more viruses are being added with their varied presentations. But in most parts, the viral uveitis imposes an illusion of simplicity because we try to put it into 3 mechanisms and 6 patterns. These 3 mechanisms are the neurotropism, the trabeculitis, and the iris ischemia, and they translate into the common 6 patterns that we use in our day-to-day practice of unilateral involvement, hypertensive uveitis, pigmented KPs, iris atrophic patches, peripheral necrotizing retinitis, and retinitis with vasculitis. And once we have identified this pattern, henceforth our treatment algorithm is fairly systematic. We see the immune status of the patient. We may do a PCR to identify the exact viral etiology sometimes, or with the phenotype, we then start the antiviral therapy with the steroid therapy and with or without steroid therapy, and we proceed with the maintenance antiviral medications as indicated. But just when we feel that we have understood this algorithm, that is when life and a few patients might humble us. They might ask questions like, why me, why now, and why again? And there are more deeper questions like, why was a PCR negative in a classical case? Why so many relapses in some patients? The unusual phenotypes, some uncommon viruses, and is the choroid spared or involved? What is the role of steroids and some stubborn macular edema after ARN? But again, due to the constraints of time, I'm going to focus on a few of them and I will refer to them as the outliers. So the first one is a PCR blind spot. This was a 38-year-old male patient who was diagnosed with Posner-Schwarzman syndrome, multiple episodes of hypertensive uveitis, treated with anti-glaucoma medications and steroids. AC tab for PCR was done twice before but was negative for the viral genomes. In one of the active phases, we noted that the patient had, when the patient presented to us, we saw that the patient had corneal endothelitis with pigmented KPs and coin-shaped keratic precipitates. So with the clinical suspicion of virus, again, we decided to repeat the AC-TAP PCR at our center. But meanwhile, we did an in vivo confocal microscopy, which showed characteristic dendritic and globular with infiltrative patterns of keratic precipitates, which was suggestive of an infective etiology. And we started the patient on anti-CMV therapy. Now, this, along with various other reports, has always taught us that the phenotype and the ancillary testing weighs much more than a single PCR report. So here we can see, even though the PCR report came positive in the third visit here, in the third attempt, but you can see the number of recurrences the patient was having earlier just stopped after we treated the patient with anti-CMV therapy. So this teaches us that PCR is not an absolute truth. The results of this, or the sensitivity of the PCR report, will depend on the viral load kinetics and the sample timing. So when PCR fails you, we must always trust the phenotype. Second is something which we don't often, articulate, but we all go through it silently. That is the viral loop. A patient presents to us, we treat, the patient responds, we stop, and then it recurs again. And many authors have tried to attribute these recurrences in the patients to specific viral etiologies, geographic factors, viral persistence within ocular tissues, innate immunity deficiencies, Th1 mediated responses, and cytokine drivers. Here, this article, which was a letter to editor on the recalcitrant herpes zoster ophthalmicus with functional natural killers and deficiency, got our attention. And we learned that the NK cells with their perforins, granzymes, and cytokine releases actually help to inhibit viral replication. And when this pathway is stopped, we can have recurrences. So this encouraged us to look at our patients, and this is our study, and this is my unpublished data. We grouped the patients into zoster recurrent uveitis and non-zoster recurrent uveitis, and we found that there was a significantly decreased NK cell count and CD56 positive NK percentage in the zoster group, and the neutrophil to NK cell ratio was higher in the zoster group. So this tells us that definitely the NK cells are playing an important role in particularly the zoster uveitis, and it is also exciting because it can have a potential of a therapeutic potential, whether it being enhancing the innate immunity mechanisms, or to give us a scientific rationale about the duration for treatment in such patients. This is another patient with disseminated varicella zoster infection. This was a aplastic anemia patient post bone marrow transplantation. He presented with a disseminated disease. And what do I mean by that? His one eye showed an anterior pseudodendritic keratitis, and the other eye showed an annular pattern of retinal necrosis. This was very unusual, but possible because of the immunocompromised status. Before I go into the uncommon presentations, I would like to recap on the typical phenotypes. So herpes simplex virus typically can present with diffuse keratic precipitates and iris atrophic patches. Varicella zoster has the sectoral iris atrophy, and cytomegalovirus can present with acute hypertensive episodes, maybe with a few coin-shaped keratic precipitates. Corneal involvement should immediately raise a suspicion for a viral etiology. Coming to posterior segment, the herpes simplex and varicella zoster can present with acute retinal necrosis and occasionally progressive outer retinal necrosis in an immunocompromised host. And the CMV has its signature patterns of fulminant, this brush fire pattern of retinitis, or a less common indolent granular form. Now, coming to the unusual patterns, this we must remember is a herpetic non-necrotizing retinitis. These are much more smaller, subtler, partial thickness lesions with minimal vitritis. They are even slowly progressive, and that's why it may mimic a autoimmune disease. But if you diagnose early and treat with antiviral therapy, they give a good response. This was a herpes zoster ophthalmicus patient who presented with vasculitis without any necrotizing retinitis, which is not common. But also it has been reported in other viruses like herpes simplex virus and cytomegalovirus. The key features here were the extensive outer retinal occlusive retinal vasculitis and neovascularization at presentation. So when we see this kind of a constellation of symptoms, we must suspect a viral etiology. From unusual presentation, I want to proceed to an unusual suspect. This was an immunocompromised HIV positive patient with a CD4 count of 154 who presented with bilateral occlusive retinal vasculitis with macular edema and having this outer retinal schisis. Yes, we did a AC-TAP suspecting a viral etiology in this patient, and it turned out to be positive for adenoviral genomes. in very high numbers. So this was rare, but definitely it gave us a clue in this case because, long story short, we did suspect a CMV vasculitis initially and treated the patient with valganciclovir and intravitreal ganciclovir, but it showed poor response. And after we took the clue from the PCR and treated the patient with intravenous cidofovir along with probenecid, that it showed dramatic response and the lesions improved, and we were able to preserve the vision of this patient, albeit some macular ischemia. So this was a rare case of adenoviral vasculitis with necrotizing retinitis. We reported it, and I want to share the learning points here that not all HIV-associated vasculitis is CMV. We must consider other opportunistic infections because you can see that the CD4 count is in a borderline range of over 150 plus. And PCR was very crucial in these cases, and it should be considered in atypical presentations and bilateral manifestations. We cannot undermine the role of, we have to give importance to the role of antiretroviral therapy for the immune recovery that can help in supporting the disease control, and timely and targeted therapy can preserve vision in these rare infections. This brings me to the last topic of choroidal spectrum. So it's only now that there are a huge number of reports that are coming in about describing the choroidal involvement in viral uveitis. Sometimes these lesions are seen as innocuous hypopigmented spots. This is typically seen in varicella zoster keratouveitis. Initially, they may not be seen because of the corneal haze and the media opacity, but these lesions have been reported by Lucini et al. As lesions which can progress and then stabilize, but they are more innocuous. They do not have a visual implication. But again, sometimes we can have viral retinochoroiditis. If you look at this pattern, this can confuse us with the toxoplasma retinochoroiditis, and it is essential to have a very close follow-up and see the treatment response once we start treating these patients with retinochoroiditis. This was a patient who also developed chronic anterior uveitis and macular edema and was managed with topical interferon. This is my last case and a very rare case and a difficult case. I must say this patient presented with peripapillary choroiditis. So this multifocal choroiditis pattern delayed our suspicion of viral etiology. But this patient, progressed into a very fulminant anterior, to a very fulminant peripheral necrotizing retinitis. It had a bilateral presentation, and moreover, it was resistant to acivir and valacyclovir, and it only responded to famciclovir. So whenever we have an atypical pattern, we must also think of a resistant genotype. And so this brings me to the end of my presentation. And I would like to say that despite all the complexities that we discuss now, we must always remember the fundamentals. That patterns still guide the diagnosis. PCR is not absolute. The timing and the phenotype matter. The host counts much more than any other infections. And viral uveitis, the immune gaps, like how we discussed, the NK cells may play a role in, and also the varied manifestations in immunocompromised patients. And we must expect the atypical because viral uveitis has a much more wider spectrum than we assume. And being alert about the atypical cases can help us preserve the vision in those patients. Thank you, and I hope you also have been ignited into some more of the enigma of viral uveitis that I also experience on a day-to-day basis. Thank you.
Thank you, Dr. Sai. That was a wonderful insight. You looked at viral uveitis in a very, I would say, in a brand new manner for our audience. And I would like to invite Dr. Amod Gupta, sir, to give his comments first, please.
Well, Daksai, you started on a great note, trying to lead us into the enigma of viral uveitis, raising very pertinent questions. But by the end of the presentation, I didn't find those answers, except for one showing the so-called outliers like choroidal involvement. Why does choroidal involvement occur? And we didn't hear your insight into why do these recur in more often in anterior uveitis compared to the viral posterior uveitis when they cause acute retinal necrosis, or why is it less often? And why do we see unilateral pathology and not bilateral? I would have liked to listen to you about the latency of these viruses and how could we possibly address the latency Is there a mechanism why they become latent? And what viruses hide where? What kind of cells? They provide a niche for hiding, and what could be the possible targets. So I thought that would fit in with the so-called enigma. What is so mysterious about these, unlike other microbes compared to other microbes? The viruses do present that kind of enigma, and that poses a challenge. And how long to treat, and how long should we give prophylactic treatment or not give prophylactic treatment? What would be the indications for prophylaxis for anterior viral uveitis and for. So what you showed was the surprises that you got, that you found different viruses like adenovirus when you're suspecting CMV, or that is the and how about the viruses? Can there be a reactivation of, say, Ebola, systemic infection from a niche in the eye? Or some such questions would be, I would think, would be the right questions to be asked uh, if you're discussing the enigma. Otherwise, it's the same as anybody else, discuss the subject. But anyway, your cases are excellent, outstanding, and that's how they got published also. A very nice presentation. Otherwise, thank you very much. But the topic has to be aligned with the title that you give. So you intrigued us with your title, but probably somewhere you got carried away. Thank you.
Thank you, sir. Can I have some comments from Dr. Neri, sir, please?
Yeah, I mean, when Professor Gupta talks, he's always, giving, great insights, and I echo what Professor Gupta said. You set the expectations at very high level because your title said everything but nothing. So in terms as like you go to a preview of a movie and then you tell me the enigma. What the enigma? You might have played anything. I mean, you might have presented, very rare, cases for uveitis. You did, because the adenoviral one was extremely fascinating. But when you set the tone for something that is extensively discussed, extensively known, I would have expected how you solved the enigma. And I do believe that that point was not really clear at that regard. For the pathophysiology standpoint, once again, I do believe that the interplay between the viral host and the potential interplay with the immune system might have been done a little bit better, because the flow of your presentation, when I listen to you, great skills for presenting, but when I dissect what the content is, since this is once again an exercise, I would advocate for you, being such a young and talented researcher, to try to focus in bringing something on the table that can change my way of acting. And that point, this can be a contribution to science that is meaningful. And when I listen to you in your 10 minutes, I can go back home and think about what you said, changing my practice. That's a goal. Other than that, congratulations. Great job.
A very pertinent point for all the presenters, on this forum. Thank you, Dr. Neri, for that. And Dr. Rohan, sir, can we listen from you now regarding what is your feedback?
Well, I really enjoyed your presentation. I think that you did a good job. You started nicely. You told about the basic viral infections which all of us are able to detect and which are the routine textbook manifestations. And then you went on to the rare cases as well. And some of them were very rarely rare, quite rare, which none of us would have seen. And the choroidal part also I've heard before from your center, Dr. Padma Malini and Dr. Ankush speak about it, and definitely now I try to look for that also when I see those patches. So that is one aspect we also touched specifically. The only thing which I think you could have added is for people is like for the anterior uveitis, you said you treated the CMV, so you could have added a little more detail of how long with what drugs, because some of these drugs are toxic, what mode, systemic, topical, a little bit about that you could have added. And then in your rare case, like you detected the adenovirus, well, why did you do an adenovirus PCR? Like none of us would routinely do an adenovirus PCR if at all. So we would just be
It is
doing
a
the
part
standard
of our
viruses.
panel, sir. It
Yeah.
is a part of our panel. It was the first time that we got it positive in so many years.
Yes, so something specific that what for others to learn how and when you would do, maybe a little pointers to that. But I think overall, I enjoyed your presentation. You've nicely covered the topic. Very well done. Thank you.
Thank you, sir. Dr. Reena?
Yes, thank you, Dr. Sai. I think I really enjoy your presentation too. But you need to think that your audience might be from other place than you, maybe have different abilities. Like in the first slide, you said that it is easy, 3 mechanism and 6 classical manifestation, and you run it very fast. Maybe there's audience that doesn't know already about this 3 and 6 easy things. So you might want to correlate your next presentation, the outliers, against that 6 manifestation. For instance, the iron, the clinical, the classical peripheral retinal necrosis with the one that only vasculitis and no retinal necrosis, for instance. So people will remember the classical one and these outliers. But I think it's really a very enjoyable presentation. And I like how you combine it with clinical and also the lab work, because the pathophysiology, you need to emphasize it, and you did your research also about NK cell. But I would like to comment about your immunological lab work. Not everybody know about, like the result of immunological work in the lab. So you need to be kind and explain it very slowly. What are your chart means? Yeah, I mean, those x-axis, y-axis, please take your time. How you have the conclusion that the NK cells are essential in this kind of pathophysiology. You need to do it, I mean, not slowly, but at least a very clear one. Your slide is your tool to give understanding, but if you give so many information without you explaining it, I don't think the slide will help the audience. I always said that we need to be kind to the audience and make sure that they are in the same pace as we are. But overall, I like your presentation a lot.
Thank you, Dr. Reena, for those amazing comments and wonderful feedback. And with that, we come to the 6th presentation for the day. I would like to invite Dr. Saloni Desai from Ahmedabad, and she will be speaking to us on primary intraocular lymphoma. Over to you, Saloni.
Yes, am I audible and the slides are visible?
Yes.
Okay, good morning, everyone. I would like to thank USI for giving me this opportunity to present on primary intraocular lymphoma. So first, I'll start with a short case to let you know why this differential is important. A 66-year-old male comes to us with complaints of blurring of vision in his right eye for 10 days. The vision was 6 and 6 and the anterior segment was within normal limits. On fundus examination, we can see the media is clear and there are a few whitish lesions on the retina in the periphery. So we investigated him further, but he was lost to follow-up, returned 2 weeks later with a drop in vision to 618, where now on fundus examination, we could see that there was some media haze and the whitish regions in the periphery on the retina had increased. And also there was a blurring of nasal and the inferior disc margin. When we did an OCT, we found there were some RPE irregularities. So we thought it can be something different also. So we ordered a PET scan for the patient. Then the patient was again lost to follow-up and returned 2 months later with further drop in vision to 636 and a PET scan within normal limits. Now, on fundus examination over and above the previous findings, we could see there was exudative retinal detachment inferiorly. And on OCT, we were able to appreciate that there were some deposits below the RPE. The patient was diagnosed outside as intermediate uveitis and unfortunately started on oral steroids. So we had to wait 2 weeks for the vitreous biopsy to be done, which came out to be positive for MYD88 gene mutation. So when we come to the introduction, primary intraocular lymphoma is now known as primary vitreoretinal lymphoma, and it is the most common intraocular lymphoproliferative pathology. Women are more prone to the disease and it presents in the 4th and 6th decade of life, usually in the immunocompetent patients. There are two major theories which support the pathophysiology for this primary intraocular lymphoma. That is, first is malignant B cell migrates and localizes between RPE and PRUs. And second is that the inflammatory B cell locates in the eye and achieves DNA mutation due to any infection. These cells then evade destruction by elaborating the interleukin 10, which is an immunosuppressive chemokine. When we come to the clinical manifestations, usually the patients will complain of blurred vision with floaters without pain or redness. On clinical examination, on slit lamp examination, we can sometimes find grayish white keratic precipitates spread all over the endothelium. On fundus examination, if the media is clear, we can appreciate focal creamy yellow to orange subretinal lesions, and in some cases, we can see dense vitritis. Exudative retinal detachments can be present in severe cases, and the disease can mimic drusenoid deposits or vasculitis or rarely retinitis. In some cases, secondary angle closure glaucoma or iris heterochromia can also be present. Next is the imaging modalities. The first most important modality which we do is an autofluorescence, where we find alternating hypo and hyper autofluorescent lesion, which is known as leopard spot sign. Basically, the lymphomatous infiltrates, they block the light. That is why we get the hyperfluorescence, and the surrounding inflammation and RP activation will cause the hyperfluorescence. On optical coherence tomography, we see pre-retinal or intraretinal hyperreflective deposits, and there are few sub-RPE deposits which give the typical moth-eaten appearance of RPE. On fluorescein angiography in the late stage, we can appreciate that the lymphomatous and inflammatory retinal infiltrates give rise to the hyperfluorescence spots at the late phase, while surrounding there can be punctate hyperfluorescence. A newer modality which is done nowadays is SSOCT angiography, where we can see hyperreflective spots on the outer retinal slabs along with characteristic perivascular flower bird-like lesion appearing as vertical intraretinal lesions. As we can see in this figure from figure A to F, with the progression in the treatment, the PFBL lesions gradually diminish in size. Also, on choriocapillary analysis, we see alteration in foveal and parafoveal areas. So how do we diagnose PVRL? So the gold standard method is to do 27 gauge transscleral pars plana vitrectomy, keeping a low cut rate of around 600 cuts per minute. An undiluted vitreous sample is collected. It is to be sent for examination within 30 minutes because these cells are very fragile and we do not want to destroy them. Also, one should always remember that if the patient is already on oral steroids, we need to stop the oral steroids 2 weeks before performing the vitreous PPV. So the classical pathological feature is large atypical B cell, which have high nucleocytoplasmic ratio, and they are found in a necrotic background. When we do immunohistochemistry, these cells are found to be positive for CD20, MUM1, BCL2, PAX5, and Ki67, and these cells are CD3 negative. We can also test the vitreous sample for interleukin 10 to interleukin 6 ratio. Why? Because the interleukin 10 is an immunosuppressive chemokine and is usually found in malignancy, while as interleukin 6 is an inflammatory chemokine and is found in inflammatory condition. That is why the interleukin 10 to interleukin 6 ratio is more than 1 and is a strong indicator of PVRL. We can also test the vitreous for MYD88 gene mutation where the lysine is replaced by proline, and that is a strong indicator of PVRL. If the vitreous biopsy is negative, we can also do fine needle aspiration biopsy where we again see the large B cells. If FNAB is also negative, we can do retinal or chorioretinal biopsy. So to summarize, if the vitreous cytology is inconclusive, we can consider IL-10 to 6 ratio or MYD88 gene mutation. And if that is not available, we can consider chorioretinal biopsy or aspirate of suspicious lesions or repeat vitrectomy. So the most common problem in diagnosing PVRL is that it mimics a lot of other uveitic entities like intermediate uveitis, infectious and non-infectious posterior uveitis, retinitis, vasculitis, papilloedema, and Fuchs uveitis. So then what are the clinical features, clinical pearls one must remember while diagnosing or when they are suspecting PVRL? The first and foremost thing is that it is bilaterally asymmetrical on presentation and it presents at an older age, whereas in uveitis, we can find varied age of population. Next is that there are no signs of congestion, anterior chamber reaction, or synechia, and we can sometimes find grayish-white diffuse keratic precipitates. In contrast to this, in uveitis, we usually have congestion, anterior chamber reaction with or without synechia, and the keratic precipitates can be granulomatous or non-granulomatous. PVRL will not have choroidal involvement. Choroidal involvement means there are either some secondaries or there is some other uveitis. The retina in PVRL will show the typical yellow lesions, and on OCT we see subretinal and intraretinal infiltrate with bumpy RP. There will be no evidence of CME or ERM as compared to uveitis. And the autofluorescence and fluorescein angiography will show typical leopard spot sign. When we come to the treatment, the International Primary CNS Lymphoma Group recommends combining high-dose systemic chemotherapy along with local and intravitreal therapy. So the local therapy consists of external beam radiation therapy, which delivers total of 35 to 40 gray. And the advantage is that there is rare recurrence, but cataract is the most common complication. When we come to the intravitreal therapy, we have two options. The first one is methotrexate, where 400 microgram methotrexate is given initially twice a week, then once a week, then once a month. And the most common side effect is corneal epitheliopathy and increase in IOP, whereas rituximab is given 1 milligram once a week for 4 weeks with lesser side effects. Systemic monotherapy includes pomalidomide, temozolomide, and Bruton tyrase kinase inhibitor, that is ibrutinib. And combination therapy includes high-dose methotrexate with or without intrathecal chemotherapy or brain irradiation or CAR T-cell therapy. So how do we monitor these patients? We need to look for vitreous haze and retinal infiltration. Interleukin-10 is a good biomarker and can be collected from the aqueous sample as well. We need to verify absence in the contralateral eye and perform MRI brain regularly. And in cases of relapse, high-dose methotrexate or thiotepa-based chemotherapy is advised. When we come to the prognosis, CNS involvement is the worst prognostic factor, and there is a new proposed OCT marker for poor prognosis, that is sub-RPE infiltrate. There is something known as IEL-SG score, which is International Extranodal Lymphoma Groups Study Group, which on the basis of your age, performance, LDH serum level, CSF protein level, and involvement of deep region of CNS classifies patients as favorable and unfavorable prognosis. To conclude, PRL represents most frequently underlying masquerade syndrome, and in cases of recurrent uveitis with poor steroid response, suspicion should always be raised for BVRL. This is my acknowledgement. Thank you.
Thank you, Saloni, for finishing in time. It was a very comprehensive overview of PVRL. Can I have some comments from Dr. Neri, please?
Sure. I mean, congratulations. I mean, it's extremely complicated to talk about intraocular lymphoma, and the way that you presented was very well structured. And it's a hot topic actually in the field of uveitis, because masquerades are always a threat. I have a few suggestions to you, because the kind of presentation that you made was aiming to have a comprehensive structure. I would say that trying to deliver potential warnings, you somehow flattened a little bit, the way of options. So let's say that when you study IL-10, IL-6 ratio, you didn't mention, for example, that you may just tap the anterior chamber if you have anterior segment involvement, and trying to understand the threshold that Natalie Cassot put in the medical literature to try to screen the patients if you have potential suspicions. Certainly, vitrectomy plays an important role. We can say that gene mutation is one of the gold standards now. And certainly when you have some things that I would have addressed a little bit more, for example, when you have retinal lesions treated erroneously with corticosteroids, and you see the jumping of the different lesions in different areas of the retina, that is one of the suspicions for intraocular lymphoma. Another thing that I would take note is that I'm an advocate of using Plexilate, but I wouldn't have utilized the time to describe that, because I consider that totally useless. because you don't add anything. Even if you solve it and you see that, you got the resolution of this epiretinal pigment epithelium lesion, it doesn't change your judgment. So I would trim this and dedicate time more on potential other threats, because there is another entity that no one talks about, which is the T-cell intraocular lymphoma, which is horrible because you test it and you tell, well, that this is a lymphoma. I'm pretty sure about this. And all the markers that you study are not there, because it's one of the minorities into and among the intraocular lymphomas. You might expand that and tell, look, when you got your suspicion, think about that, because this can happen even though the largest cohort is only 14 cases and has been published, I think, like 7-8 years ago. To summarize, great job. But since you aim to become an expert of this specific topic, try to bringing what were the real concerns that you had, and try to give a pitch to those who are listening to you on how to get out, the mud, because sometimes when you deal with that, you are really in troubles. And even for the treatment, last but not least, the chart, I don't agree how it was presented, because you said treatment and then you have different branches. As Lee Jim Paul said a few days ago when I met him in a meeting, this is a systemic disease and is a fatal disease. You can't treat just locally. You need to aim to have systemic treatment no matter what, because it's a straight killer and the survival rate is very low. So you need to be extremely thorough on how you address this. And those are just aspects that I would refine a little bit, but great presentation.
Thank you, Dr. Mary. Can we have some comments from Dr. Amod Gupta, sir, please?
Yeah, I agree with what Professor Neri said. And Saloni started on a great note, showing a case. And I would have used that opportunity while she was presenting that case to highlight on all the aspects, the OCT, the fundus autofluorescence, and the presentation, and what were the challenges in diagnosing it, and how did they finally get to treat that patient. So if she had uh, told the story of primary vitreoretinal lymphoma through her patient as it unfolded, it would have made a great case, and very illustrative case for that matter. To bring in, extraneous investigations didn't really help. So if they did all those IL-10, IL-6 ratio, or I guess only the MYD85 mutation was done. So we need to know the sensitivity of each of these IL-10 and the gene mutation, as well as the ophthalmic imaging, signatures of the disease. And I'm not sure when you said that sub-RPE presentation of lymphoma carries a bad prognosis, because that is the hallmark of this. I thought one of the most characteristic feature is the what you showed very briefly in your case itself, the sub-RPE deposits. The nodular lesions, which are kind of sub-RPE. That is how we see, and the other is the leopard skin appearance. I would, while agreeing that we need to treat all these patients systemically, I think you could have highlighted the role of a team approach, including the neurologist and a medical oncologist in managing these cases. To say that we are going to treat all alone these cases would be rather expecting too much from an ophthalmologist to treat these. So I would have the radiation oncologist, a medical oncologist, and a neurologist who see bulk of these cases actually, because bulk of these CNS lymphomas don't develop ocular, involvement. So they hardly ever send those patients to ophthalmologist, because they're managing them on their own. But since we find that most of the ocular presentations would eventually develop CNS, So we need to bring in the neurologists, and for management, the medical oncologist, and if need be, the radiation oncologist. So it's a teamwork managing. If you had highlighted that, so that we don't start treating ourselves as ophthalmologists, and how long do we follow them up, and what are the modalities? How frequently should we do MRI scans of the brain, and how should we monitor the ocular lesions once we have completed the therapy? So that should be the questions addressed if you are going to talk about this subject. Thank you. Otherwise, very nice cases, and could have been better organized, I would say, and some. Thank you.
Thank you, sir, for the wonderful comments. And can I have some comments from Dr. Rohan, sir, please?
Yeah, Dr. Saloni, nice case and nice presentation. But just a few pointers regarding the presentation itself. I felt that some of the images, I think probably you could have enhanced the brightness and contrast and maybe the size and all, so that makes it a little more easier for the audience to visualize exactly what you are trying to show in the image. You could even have put some arrows or some pointers, so that I just think enhances the presentation style. And otherwise, you have stressed upon the leopard spot different point, but you could also have mentioned along with it the differentials, because it is not just, it is just pathognomic and it is the only lymphoma can have leopard spots. Other conditions can also have that. So maybe you could have put the differentials over there. And what sir said, the sub RP deposits, which are the hallmark, that needs to be specifically highlighted, and specifically you need to mention that it never would breach the Brooks, the PVRL. And about the treatment also, like Dr. Neri mentioned, that also would have, you should have stressed a little bit more between the difference between lymphoma which involves the CNS and which does not involve the CNS at first presentation, and how you would differently approach that. Although, like sir said and Dr. Neri said, that most of us believe it's a systemic disease and we would treat it aggressively with systemic therapy as well. But there is a school of thought from US, I think Dr. A.D. Singh, who also believe that maybe it is a multifocal separate involvement, and sometimes if it is a unilateral ocular disease, you will be over treating, giving systemic treatment and all. So that is also a point of view which is present in literature. You could have brought that out as well. And treating itself with the multiple intravitreal regime is a difficult issue with its own set of side effects that could also have been presented. Thank you. Thank you for your presentation.
Thank you, sir. Dr. Reena, can you give us the final concluding comments for Dr. Saloni's presentation?
Thank you, Dr. Saloni. I think your presentation was very thorough and systematic. But I would like to suggest that in every presentation, you need to make it personalized on your own, because from your overview, you see there's introduction and there's clinical manifestation. Imaging is really similar to a book, but instead you need to make a point of view from your side. What is your problem in the clinic and what you think it is important and you're passionate about. For instance, in Indonesia, we are even having difficulty in ophthalmologists that can recognize the pathognomonic sign. I will approach it by maybe elaborating the clinical signs very detailed and correlate it with pathophysiology. That is your own take, what is your edge in your presentation. If you make it like a textbook, then everybody just read the textbook. So, for instance, I know that I also have similar discussion with several experts in the Netherlands, and they are also opting to give just the systemic medication for intraocular lymphoma, because at the end it will reach systemic. So maybe you can also approach in that way to see the different point of view and what is the result of the treatment, for instance. But I think it is a very nice and thorough presentation. You can understand the topic very well, but you need to make it your own presentation. I think that's my final conclusion, Dr. Arshi. Congratulations, Dr.
Thank you. Thank you, Dr. Reena. That was a very, very key point you put across, that is to make the presentation your own. There has to be that personal touch to it. I totally agree with you. Thank you very much. And with that, I would like to invite our penultimate speaker for the day, Dr. Taluri Roni Abhishek from LV Prasad Eye Institute. He will be speaking to us on the general principles of treating cataracts in uveitis. Over to you, Dr. Roni.
Thank you so much. Thank you, sir, for this opportunity. Today, we'll be speaking about the general principles in treating uveitic cataracts. So, our objectives for today will be discussing the problems that we face during the cataract surgery or after the cataract surgery in uveitis, and also to understand a tailored approach while performing the surgery. So you must be familiar with Chandrayaan-3, which is a failure-proof model, meaning the design was made based on the problems which were faced on Chandrayaan-1 and 2. As a result, those problems were anticipated, and this failure-based design was made to mitigate the problems. Our treatment approach to uveitic cataracts is also a failure-based design based on the problems that we had faced earlier during the surgery and after in the post-operative period. So, what are those problems? Band-shaped keratopathy is a very well-known problem that we face in JA-associated uveitis, and it can tamper the view while we are performing the surgery. It can also be seen in many of the adult cataracts with chronic uveitis. EDTA chelation can help us clear off the PSK and have a better view for the surgery. Small pupil is one of the most common problems that we face while we are operating cataracts in uveitis. And we have many appliances that can be used in order to have a good, adequate pupil dilatation in order to have a safe and a smooth surgery. Sometimes even due to the pupillary membrane, the pupil can be small and which can also be dealt with. Peripheral antisynechia are present, can be present in the preoperative period, especially in cases of sarcoidosis and in chronic uveitis. Also can present after the cataract surgery if the inflammation is not very well controlled. As in this patient, the IOL has been placed in the sulcus after the cataract surgery, but the cortex was not very well removed, as a result of which it has caused chronic inflammation within the eye, causing this anterior synechia. We can appreciate here in the inferior. And we tried to explant this IOL. 15 minutes into the surgery, there was a huge descemal membrane detachment. So the point I'd like to stress here is that when we are operating through the anterior segment and when we are placing the side port plate, we should be very careful of this peripheral antisynechia. Retropupillary membranes can be formed over the IOL and behind the IOL, resulting in cocooning of the IOL. Most likely or most commonly seen in patients with chronic uveitis in the pediatric age group or in JA-associated uveitis after the IOL has been placed if the inflammation is not adequately controlled. These cases are very difficult to manage and eventually might lead into hypotonia. Capsular phimosis or posterior capsular opacification is one of the most common problems that is encountered after the cataract surgery, sometimes even when the inflammation is thoroughly controlled. So, in order to prevent these two problems, a good sized anterior capsular excess and also to perform a posterior excess at the same sitting would help. If the inflammation is not very well controlled by the time the patient was taken up for the surgery, or if there is immediate spike of inflammation after the cataract surgery, it can lead to this pupillary blockade and the formation of synechia and iris bombay. In such situation, it would be very difficult in order to do a yak iridotomy. So better we do a big sized peripheral iridectomy during the surgery itself in order to prevent this iris bombay in the post-operative period. Recurrent flares are also well seen, and the immediate postoperative inflammatory spike is of utmost importance, which should be controlled. So, administering deposteroids during a surgery or using IV methylprednisolone before, after, and during and after the surgery can help to deal with this recurrent flare-ups. Sometimes we won't be able to see the posterior segment because of the small pupil and the dense cataract that can be present. Cystoid macular edema cannot be anticipated in the preoperative time. Getting an A scan with the help of this size machine can give us a small OCT at the macula, where we can see here that this patient had macular edema, suggesting that the prognostic outcome of the visual acuity later. Similarly, vitritis also cannot be anticipated much because of the small size of the pupil. So getting a B scan is also of utmost importance while the patient is being taken up for the surgery. Combining pars-plana vitrectomy along with cataract can help us in two ways. It reduces the inflammatory load in the vitreous, and also it can reduce the total immunosuppression load that is required for the patient after the pars-plana vitrectomy. Anti-segment findings can be sometimes misleading. Even though it appears that the inflammation is controlled, we might not actually know what is happening at the posterior segment. So, after performing the cataract surgery, it is better to have an intraoperative retina examination so that we can understand the etiology, understand whether the disease is active or inactive, and also to look for the prognostic factors like having a pale disc or a macular scarring while performing the surgery itself. So let's look into a case, a 66-year-old male who had presented with gradual diminution of vision in both the eyes, and visual acuity in the right eye was 20/40, while in the left eye was 20/100. Left eye, you can see a thick pupillary membrane, and since the small pupil is present, we have also did a B scan which showed a dot echo suggestive of vitritis. So this patient has been taken up for a combined surgery of phaco along with pars-plana vitrectomy, since the patient did not have any recent episode of redness in the recent past for at least in the last 3 months. And this is the video. We have done a pupillary expansion under an ACM so that we do not have to use viscoelastic before staining of the anti-lens capsule. That way, making sure that the capsular staining is adequate. And the pupillary membrane has been removed with the help of vitractor. Phenocan has been installed, and an adequate staining of the capsule has been done. Visco expansion of the pupil has been done, and an adequate rexus size. Making sure that the phaco is done thoroughly and completely, and we should make sure that do not puncture the posterior capsule, because we require that the IOL should be placed inside the bag and bag alone, and we do not want it to place it in the sulcus, resulting in formation of membranes later, or a scaffold for it. Once the IOL is placed, we proceeded with pars-plana vitrectomy for this patient. Pars-plana vitrectomy can also help us in a diagnostic way when we want to take a vitreous biopsy when we are in a dilemma of the diagnosis. And once the pars-plana vitrectomy is done, a posterior capsulorhexis has been performed and followed by a surgical peripheral iodectomy. And we close the case by giving a posterior subtenon injection. So these are the post-operative picture in the left eye. You can see the adequate size of the anterior capsular axis as well as the posterior capsular axis and a patent surgical iridectomy. And this is the other eye which was taken up later, where we perform multiple iridectomies for the patient. So we arrive at a tailored approach while looking at all these problems that can be faced during the surgery and also in the post-operative period. So perioperative control of inflammation is of utmost importance, and if it is a case of viral anterior uveitis, better to start the patient on antivirals beforehand. Pupillary dilatation is can be performed with the help of pupillary expanders. The membranes can be removed with the help of a forceps or with the help of a cutter. We need an adequate pupil size so that the surgery can be performed in a smooth manner, and the rexus size is also of adequate size. Phaco administration should be performed with utmost care so that we do not rupture the posterior capsule, and the IOL should be placed inside the bag. Cortex has to be removed completely. Performing a posterior capsulorhexis can prevent the formation of a PCO in the postoperative period, which can be performed from the pars-plana route or from the anterior route by dipping down under the IOL. Pars-plana vitrectomy can reduce the inflammatory load and also the immunosuppression load after the surgery. performing multiple peripheral iridectomies or a single large iridectomy to prevent the formation of iris bombay and to give up deposteroid, either posteosubtenon or a triamcinolone injection. So to conclude, ours is a failure-based design, looking at all the problems that we face during the surgery and after the post-operative period. And this treatment approach where we address all the issues at one go. Thank you.
Thank you, Dr. Ronnie, for adding a new dimension to the topics and discussing in detail about uveitic cataracts. So can I have some comments from Dr. Reena first this time, please?
Yes, thank you, Dr. Arshi. Congratulations, Dr. Ronnie. I think you have a very balanced and clinical grounded presentation, because I know you're trying to approach what can go wrong and how to anticipate everything. But I would like to just add a little bit improvement, probably if you have those things that can go wrong, you can make it as one in one case, but maybe you need to structure it a bit, maybe what to do before surgery, intra-surgery, and post-surgery concisely. Because now everything is put differently, like you presented in the beginning, and then there's a case and you present it again. Maybe you can save some times and make it more detailed in every step. I think that's only the improvement I would say, because I think you have already explained everything very clearly, and the surgery also explained very well. Congratulations again, Dr. Ronnie.
Thank you, Doctor.
Thank you, Dr. Reena. Dr. Amol Gupta, sir, will you please share your feedback?
I think we started on a great note, Dr. Ronnie, and I was hoping to see how you anticipate any problem that arise. And to that extent, I didn't see the preoperative evaluation. For instance, what cases would you do a gonioscopy, or would it be a mandatory evaluation to look at the peripheral entry synecdoche? I didn't find any mention of intraocular pressure. And whether it's a low intraocular pressure or is it a high intraocular pressure, how do you deal with that challenge? And your calculation of the IOL power, if you plan to put an implant, do you universally put implants in all the eyes, all the patients, even if they are hypotenuse, or if their axial length has been reduced because of hypotony? And do they apply to all the age groups or all the types of uveitis? Because I think if you had focused in these 10 minutes on a very specific, and again and again we come back to the most problematic and challenging cases are the cataracts complicating juvenile idiopathic associated arthritis associated uveitis, GIA associated uveitis in young children, because that is where we have to take a big call. Would you switch to biologicals, or would you continue with the immunosuppressants, the conventional DMARDs, or you would switch to biologicals for the duration of this, or would you put an implant, and what would be the contraindications if you are? Would you do a vitreous surgery in all these patients of GIA associated complicated cataract, or you will not do that? So what are those cases? I mean, you did try to show a surgery which was I thought was superfluous. It was not really required to show cataract surgery steps, and there was no new perspective in showing that surgery, except that you did it. So I think it's again a very vast subject, and you could have focused on some of the aspects like preoperative, operative considerations, post-operative considerations, how long? Because cataract surgeons don't like to see their patients after a month or 6 weeks. Whereas in a patient with uveitis, When do you anticipate these complications like cystoid macular edema? Or doing a vitreous surgery, does it eliminate the occurrence of cystoid macular edema or epiretinal membranes or other complications, retinal detachments and others that may occur? So how long would you agree? When do you see cocooning? I was hoping to hear more about that because the cataract surgeon is very happy putting a lens in the bag, but come 6 months or 1 year and the implant is lying outside the bag, totally fibrosed and cocooned. So some of those, how do you deal with those surgeries, post-implant surgeries, where there is a cocooning and you have extensive additions between the capsule and the iris, and development of neovascularization and stuff which happens. So I think it's again a huge subject which you could have focused on one or two aspects of that surgery rather than going to enumerating all those things which you do. Like expanders and other things. I think you were wasting time how to dilate the pupil preoperatively or peroperatively. Those things are given. So some of the critical issues could have been addressed. But, otherwise, I think the great attempt in introducing a new concept of fail-safe surgical procedures or approach to management of cataract surgery. Thank you very much. And thank you.
Thank you, sir. Dr. Rohan, sir, can
Yeah.
you share with us your feedback, please?
Yeah, Dr. Ronnie, I think as has already been said, I think you could have structured it a little better, pre-operative, much more detailed pre-operative considerations, intraoperative, and then post-operative. But having said that, sitting on the other side for us, I think it is always easy for us to give comments. So please do not take all of these very negatively. But all that what we are saying is to try to improve upon your presentation and also give some pointers from our own experience to the audience. So otherwise, all of you have done a very, very good job and good presentations. So again, coming back to your presentation, some specific more points. You showed a 66-year-old person, this person who was undergoing surgery. So at that age, probably the patient would not even have had an active uveitis for past decade or so, maybe. So maybe that was not the pertinent case which you could have shown. You could have taken a case of JIA or some more active uveitic disease and shown how you managed the intraoperative part as well as the postoperative long-term follow-up, what sir was mentioning. And then you advised vitrectomy. Well, it's a concept and can be definitely done, but most of us would not be doing it in all cases, specifically not in a 66-year-old with an inactive, maybe past uveitis. So you need to tell us more when you decide to do it specifically, and what is your rationale behind it if you want to advocate it on such a forum. And otherwise, specifically, I would also in this touch upon Fuchs uveitis, which I think many cataract surgeons refer to us when they see a few cells and not realizing that probably this is the best cataract surgery case to do in a patient of uveitis, which might have the minimal complications. So recognition of that also is important while doing a cataract in a uveitic case. So yes, divide your presentation into these pre-operative, intraoperative, and post-operative categories, and that would make it more systematic. Thank you. Thank you.
Thank you.
Thank you, sir. Dr. Neri, sir, please.
Sure. I mean, Dr. Ronnie, I mean, first of all, I mean, the presentation was great. I have no comments about it. I mean, the only thing that I would say is that you presented as a cataract surgeon to uveitis specialists, which is not what we are here for. So the point is that you should have crafted your presentation from a uveitis specialist to cataract surgeons. So it was like I invited a cataract surgeon to teach me on how to do cataract surgeries, but I don't really care about on how to do this. And I echo what Professor Gupta said, that, the video was just there. But I mean, I don't really pay attention on that. The most important thing is how I prepare the patient, which kind of concepts I use to make the disease, have the decision making in, approaching the cataract in a certain way. Should I implant or should I not implant in juvenile idiopathic arthritis associated uveitis? When and how? You may have also acknowledged that there are some authors telling, yeah, you need to implant no matter what. In other cases, no, you have not to. You need to wait and use the contact lenses, for example. So there are things that are related on the way you present. And there is one thing that you need to ask yourself is that, I mean, certainly you're a uveitis specialist, but I thought what has been asked to me for a job interview. They told me, are you a retina specialist aiming to be a uveitis specialist or a uveitis specialist working as retina specialist? So you need to understand what you want to be in life. And that crafts the way you present. Because if you were a cataract surgeon presenting to uveitis specialist, flawless. But if you are a uveitis specialist presenting to cataract surgeon, I would refine your presentation the way that we suggested.
Thank you.
Thanks a lot, Dr. Neri. And with that, we move to the final presentation of the day. I would like to invite Dr. Tanya Jain. She will be speaking to us on recognizing retinal signatures in subacute sclerosing panencephalitis. Over to you, Dr. Tanya.
Hello and a very good afternoon. Am I audible?
Yes, you are.
Yeah. All right. Hello, everybody. First of all, thanks a lot for this opportunity. Feels really great to be presenting here. So I'm going to talk about my journey and the lessons that I've learned in dealing with these very difficult patients. So I'm going to start back in 2019. This is the first case. A 16-year-old female from Uttar Pradesh came to us with diminution of vision in both the eyes, no other systemic history, and apart from the fact that she had a history of facial palsy around 2 months back. So if you look at her, there's some residual facial palsy in her. Other than that, she looks like a normal happy child. However, her vision was 3/16 both the eyes. And if you look at her retina, there is a posterior pole retinitis in both the eyes. The right eye appears to be scarring. The left eye appears to be a bit more active. In the periphery, there were just few vasculitic patches. Other than that, it looked okay. However, her OCT, if you see her OCT, there is a full thickness kind of retinitis, necrotizing retinitis with a typical moth-eaten appearance in the right eye, and the left eye passing through the fovea shows that the macula is scarred. So this is actually atrophy, and on FFA doesn't really tell much apart from the fact that the lesions are confined to the posterior pole and there's no disc leak. These lesions just stain at the end and block fluorescence due to the hemorrhages. So we were clueless. What were we dealing with? Her uveitis profile was fine. Was this viral retinitis? However, was it PORN? However, it was not only outer, it was full thickness retinitis. So on review of literature, we came across this subacute sclerosing panencephalitis caused due to measles. It typically causes this moth-eaten appearance. So keeping in mind age group, her low socioeconomic status, unreliable vaccination history, hint of CNS involvement, and bilateral necrotizing retinitis, we advised a bunch of investigations and sent her to a neurologist. And for us, the working diagnosis was SSP-associated retinitis. She came back 10 days later. Her lesions appeared to have scarred. The neurologist completely did not agree with us. He said the CNS was fine, did not do anything, and sent the patient away. We lost the patient. She came back again 2 months later. She had total loss of vision, loss of orientation, withdrawal from surroundings. She had involuntary jerky movements and loss of bowel and bladder control. And this is how this poor girl looked now. We sent her back to the neurologist. Now the CNS exam was not possible, and she was no PL in both her eyes. There was complete scarring at the macula and the complete optic atrophy in both the eyes. Now they did the CSF analysis, and it turned out to be positive for CSF total IgG, and the CSF to serum quotient was 4.48, which is of any value of more than 1.5 is considered to be indicative of measles-specific antibody production in the CNS. This is her MRI report, and the MRI also clearly shows demyelinating disorder in her occipital and parietal lobes. And the EEG showed these periodic spikes, which were suggestive of myoclonic epilepsy. So there's a criteria known as the Dykens criteria, which is used for diagnosing SSPE. So we had this clinical signs, we had the EEG, the CSF, and the measles antibodies, everything. And of course, the brain biopsy can be done only after, the patient is diseased. All the four were positive, and the diagnosis was confirmed. It was SSPE. She was advised intrathecal interferons. However, the patient was completely non-affording. She passed away 4 to 5 months later. This was approximately 6 months after she presented to an eye doctor. We, of course, published this. However, we learned many important lessons from this patient. So if a patient comes with macular necrotizing retinitis, full thickness involvement, young patient from a low socioeconomic background with unknown immunization history, it may point to this very fatal disease called SSPE. It has typical moth-eaten appearance. The lesions scar very quickly, and it is very difficult to convince neurologists sometimes because it is such a rare disease. These patients sometimes may present to an ophthalmologist, and it's important to remember that 50% of these patients actually have eye signs. Now, 3-4 years later, another patient comes to us. She's an 18-year-old female from Rajasthan. She does give history of some jerky and involuntary movements. Her vision is 2/60 and 6/12. Right eye again has this posterior pole retinitis. However, if you see the center, it is scarring. And in the left eye, it is not so much pronounced, but there is some focal retinitis and some hemorrhages. So the autofluorescence shows us the degree of the retinitis, and on OCT we can again see, even though it is scarred, there is full thickness retinal involvement. From learned from the previous patient, this really pointed towards SSP. So, however, I just want you to note one thing, that there is absolutely no disc leakage in both the eyes on FFA. We again sent this patient to the neurologist. The MRI report actually had hyper intense optic nerve heads, and it said that it had bilateral optic neuritis. So the neurologist actually just stuck to the problem of these optic neuritis, and they stuck to a diagnosis of MOGAD. MOGAD is myelin oligodendrocyte glycoprotein associated antibody disease, and is usually diagnosed if you have these two antibodies, which were actually negative in this patient. Also, upon reviewing the literature, there is no known association of retinitis with MOGAD. We kept telling them, however, even after sharing cases and case reports, they refused to do a CSF measles for this. They did a CSF tab, but did not send it for measles. They made a diagnosis of multiple sclerosis, started the patient on rituximab. We lost the patient 6 months later, which for us confirms a diagnosis of SSP. So lessons learned from this patient, that usually it is such a rare disease that even the neurologists, it is very difficult to convince them. Not all patients may present with typical moth-eaten appearance, but a posterior pole retinitis full thickness retinitis should really alarm us, and we must rule this disease out. Again, another patient we saw a year later. Now he's a 15-year-old male. He's very well immunized, showed us the immunization records and everything. He's fine, but came with diminution of vision both eyes. These were his retina photos. There is again posterior pole, looking like posterior pole retinitis. My two DDs, where one was, is it like a Best disease, or other one was again SSP. So the FFA clearly demarcated the retinitis lesions. The ERG and EOG was normal, ruling out any, Best disease. And the retina showed again full thickness kind of retinitis with a moth-eaten appearance. However, we were pretty experienced and did everything for this patient. However, everything came out to be negative. But this patient, without any treatment, nothing, we didn't even give him megabrom or NSAIDs. He scarred, and it was 636 in both the eyes 1 week later. So there are a few case reports of a waxing and waning kind of episode of SSP. So we have kept him under observation. Another patient, now this is a male, he's a 17-year-old male. Recently seen him 1 month back. Again comes with this kind of posterior pole, retinitis with hemorrhages. and the OCT typically has this moth-eaten appearance, so eerily similar to the first patient. Now we are much more, better equipped to diagnose this, and we are following up this patient. It's pretty recent. So what have we learned? This beautiful article by Jeffrey et al. It means SSP is a progressive neurodegenerative disease, which usually occurs 7 to 10 years after a measles infection. The latency may vary from 1 month to actually 27 years, and the usual patients that you see are usually children around 18 years of age. It is caused by cerebral involvement of the measles virus, which causes destruction of the neurons. As I said, 50% of these patients may have eye findings, and the Dykens criteria, which we discussed, the diagnosis is made by that. There is no known cure and no known survivor of SSP, but it may present to you as an ophthalmologist, and one must really, look out for this deadly disease. Other eye findings that the patient may present with may include sometimes papilledema or papillitis or optic atrophy, sometimes cortical blindness or Anton's syndrome. But why am I talking about this today? Why is it really relevant today in 2025? So India is not yet a cure of measles, and our vaccination profile is also not good. However, US declared USA to be measles free in like around 10 years back, and now there is a resurgence of measles. In 2025, there were a total of 1,681 confirmed cases of measles in the US. So it actually may be relevant, and every ophthalmologist should know about disease. So to conclude, there's a resurgence of the disease. Bilateral macular necrotizing retinitis may point towards SSP. These patients are usually young, from a low socioeconomic background, large families, and unknown immunization history. Neurological findings may be present if you ask, or sometimes it may just be ocular findings, and vaccination is the only way to prevent this deadly disease. Thank you, everyone, and thank you.
Thanks a lot, Dr. Tanya. It was a very great presentation. Some really rare and challenging cases you put across. And let us listen to the feedback from our judges. Dr. Ramod Gupta, sir.
Well, Tanya, congratulations to you for making an excellent presentation of rare disease and a very classic example of experiential learning. You learned from your own experiences to warn or to send warning signals to the rest of the ophthalmologists in the world. Because, as you rightly pointed out towards the end, measles vaccination has been stopped in the US, whereas in our own population, majority of the people, children don't receive this measles vaccination. It used to be given as a part of the measles, mumps, that kind of. Now it's almost everybody doesn't get it. There are a lot of gaps in this program also. And more importantly, even if they are given vaccine, the measles infection, if it occurs before the vaccine is given, it's a mutant measles. It may not manifest as a clinical measles and yet produce SSP. And you rightly shown those signatures of SSPE in the macula. It's the most progressive, and we've had that experience, reported also, that it's the most progressive. So if you see from day to day progress, and I would recommend that you document them every day, you will see the progression of the lesions. It doesn't happen that way in toxoplasma. And some people have reported similar kind of necrotizing retinitis, full thickness, with sparing of the internal limiting membrane and the Bruch's membrane in this disease. But the progression that we see in SSP is remarkable. Within 3 weeks, you have those radial spokes of the scarring, which is happening in the macular area. So it's a very, very classic presentation. And why ophthalmologists need to recognize it, because otherwise they have a patient whose parents are going to chase you forever in life, that you didn't warn us that this was a fatal disease. So rather than us breaking the news to the parents, maybe it is the neurologists are called upon to give that advice. And you rightly chase the neurologist, and they insist because of their ignorance. So only people who don't consider your recommendation are ignorant neurologists, and you should have sought the opinion of some other neurologists, who would listen to the reason. And you need to supplement with maybe literature, maybe with sporting literature, which we have done in the past when people were so dumb that they wouldn't listen to something very logical. But an excellent presentation you made, very nicely demonstrated. Congratulations once again. Thank you.
Thank you, sir.
Thank you for your remarks, sir. Dr. Neri.
Well, Tanya, I think that your was an excellent presentation that can be described like a case-based dissection of a very complicated topic. I like the way that you presented. Cases were extremely clear. As Professor Ahmad said, those are rare cases, very complicated, life-threatening. So the structure of the presentation was very sound. I would say that I don't have found many flaws in your presentation, which is a great merit. The cases are pretty well interconnected. Pictures were very well presented. I do believe that you have utilized the time very well. And another thing that I would say as a merit is that you have given somehow your personal perspective. So didactically speaking, you made a great job, and I do believe that you have utilized very well the time that was given to you. Congratulations.
Thank you, sir.
Thank you, sir. Dr. Rohan.
Yeah, Dr. Tanya, very nice cases and very nice presentation. And you really told the main crux of the case, that if a person sees these bilateral necrotizing retinitis at a macula in a patient who's in the second decade or even in the first decade, the first suspicion should be SSP, which is what the point should go across, and you've made that very clearly. They may or may not have myoclonus jerks. But just to add from my experience, like you said, the first diagnosis should be, first suspicion should be SSP, and the investigation for CSF should be done. But one odd case that we have seen, we again found none of these to be positive. And in a patient we have described where the only indicator we found was serology positive for a herpes group of viruses, and that patient is alive. So, and it also scarred, but it is, and there's not been any progression. And one rare case again where the patient is deceased, but they did a brain biopsy and their measles and all was negative, but they found an NK virus. So some rarely other viruses also can cause this. But yes, the point should go across is that if you see such a patient, first suspicion should be SSP. Yeah. Thank you. Nice presentation.
Thank you.
Thank you, sir. Dr. Veena, final comments from you, please.
Yes, thank you, Dr. Arshi. It is actually very shocking for me because you're not, Dr. Tanya, you're not just presenting one case, but you have 4 cases. And I really like how you present the case. The flow is really nice. You have this calm pacing, presenting the presentation, logical sequencing of the history. I really like it. You emphasize also the red flags. So this presentation is very easy to follow despite the complexity, and I like the way you tone your voice, that you showed this is you are very firm in your presentation, but also there's I can feel the compassion in your presentation, because this is a very alarming cases to be happening in this era. So I think maybe just one suggestion, since you covered multiple cases, maybe a brief summary slide at the end highlighting the key red flags for every learning points will be helpful for the audience, and it can consolidate your message even better. But overall, this was a very thoughtful, well organized, and highly educational set of cases, I think. Thank you.
Thank you.
Congratulations, Dr. Tanya.
Thank you.
Thank you very much, Dr. Tanya. And with that, we come to the end of phase 2 of NextGen USI. A total of 16 speakers have presented till now. And before I conclude and hand it over to Dr. Partho, I just wanted to highlight a few important points which were made across these last 2 sessions. As was said last time, there is no right, there is no wrong, there is only room for improvement. So I wholeheartedly agree. And a few tips regarding the presentations, presentation skills, which were mentioned by all our judges today, is at the beginning, at the onset, acknowledge images which you take from other people or from publications. It is important to pick up focused topics and then to be able to touch in detail on that, especially when you have a limited duration of, like, say, a 10 minutes talk, and your content should align with your title. So most of the judges also felt that sometimes today the content did not really match up their expectations as far as the title went. So it is important to align the two. When you are putting up pictures, etc., it is important to have slides with lesser explanation, more pictures, have more uniform fonts, and use arrows and images as it's required. Make the presentation your own rather than having going by the book. So these were a few tips regarding the presentations for younger fellows and postgraduates who are listening today. As far as the Uveitis content went, regarding the NUV task force, the judges agreed that the idea of that was to propose for a more targeted investigation and to help non-Uveitic experts develop a methodology rather than to aim for universal acknowledgement. As far as pediatric uveitis went, they made a very important point there, that it is important that we specify that drugs like intravenous methylprednisolone is used for rare cases like maybe pediatric PKH or pediatric Behçet's rather than as a blanket therapy for all pediatric patients. And the next talk was on anterior uveitis. So the judges felt that it was important to highlight that the posterior segment is viewed always and that uveitis is treated aggressively from the beginning. As far as viral uveitis was concerned, a lot of questions were raised regarding as to how we can better the presentation in terms of which kind of viruses are infecting which tissues of the retina and why. So there were a lot of new questions raised, which is food for thought for future presenters on this topic. When they were discussing PVRL, all the judges agreed that it is important that systemic treatment is extremely important, and a more team-focused approach involving the medical oncologist, the radiation oncologist, and the neurologist is important. And it is difficult as an ophthalmologist to treat this condition alone. To keep rare things like T-cell lymphomas also in mind when you are dealing with these diseases. Towards the end, uveitic cataracts were discussed, and it is important to highlight the pre-operative assessment and preparation which you do along with the intraoperative techniques as well. And towards the end, we discussed rare cases of SSPE, highlighting that it is important to look for warning signs, and experiential learning, as Dr. Gupta mentioned, is a key, and looking forward to great presentations in the future. With this, I would like to thank all our judges for these superb pointers that they have all given us. Such a positive energy and a positive vibe throughout these 2 sessions wouldn't have been possible without all our judges here who have taken out time over 2 weekends and dedicated their time to the betterment of our USI members. Can't thank you enough. Thank you very much. And with that, I would like to hand over to Dr. Partho for his concluding remarks.
I think thanks to our judges and all the 16 participants who has participated in this first time this kind of NextGen meeting. So I believe the NextGen was one of the first sessions where expert reviewed each presentation closely, dissected it, and shared very practical tips which help not only these participants, but anyone who wants to improve their presentation skill. And people like us also, those who are presenting, we have learned so many important tips and tricks, like how to decide a topic and how to focus on that. So thanks to all the judges, I really appreciate the way you made yourself available for this 2 days, 2 Sunday you spent with us, gave us important tips, and actually we learned a lot. So as organizers, we have learned a lot, and we plan to continue this event every year. And while conducting this meeting, we came up with so many suggestions and advice and feedback. So we'll frame it differently next time, little differently, and take participants from all, like participants, judges, and the audience before planning the NextGen 2026. And our sincere thanks to our wonderful moderators, Abhilasha and Arshi. I really appreciate the way both of you conducted this webinar. And a special thanks to our event host, Mr. Sunil. And that's all for today. Good day.
Well, thank you. Thank you all.
Thank you,
Thank you,
everyone.
sir.
Thank you, everyone.
Bye-bye.
It was
Thank
really
you.
wonderful.
Goodbye.
Thank you.
See
Thank
you
you.
next year now. Thank you. Bye-bye.
Thank you, sir.
Bye-bye, sir.
Thank you. Thank you.
Bye-bye.
Bye, sir.
Very nice. Congratulations.
Thank